This conference will now be recorded.
So my apologies, there had been some issues with the session I had booked earlier. The audio wasn't working in that, so just need to shift this. Okay, so labor ward management. And we're going to start straight away. So Atya couldn't do any last time because there were some mic issues for Atya. So Atya, we're going to start from you if you have joined us.
Yes, doctor.
Right. Okay, so this is our first room. Okay, that's your first 2 minutes.
Yes. I'm Dr. Atiya Rahman, one of the exam candidates and ready for the discussion.
Right, okay. So would you like to summarize your case first?
The patient is Demi Ford, 36-year-old, primary gravida. She's 29 weeks preterm pregnant with an IVF pregnancy, and she's admitted to our. She has been admitted for an hour ago with a history of type, with no other medical concerns or surgical concerns.
Okay. So what are your immediate approach?
Okay. Okay. My immediate management would be that I would see the patient. I would try to assess her general well-being. I will try to assess from her history that as she has no medical concern, no surgical concerns, that any other issues that she has, that any shortness of breath, any presenting complaint, any problem, any leak from the down, any leaking from the fluid, any discharge that she may have, any fever that she may have been suffering, or any other symptom that could have been related, to assess the certainty that is she in a to diagnose the preterm labor and to diagnose the preterm pre-rupture of membrane, is it there or not. And I will assess through her history regarding regarding the history of any clots in her leg or lungs, regarding her family history, which is not there, to make sure that to assess her risk for clotting and VT risk assessment. And I will also assess her support. She's coming alone or she has a support. And in other than the history, I will after that, in the presence of a chaperone and in the presence of with the help of my midwife, I will assess her vitals, like check her blood pressure to assess her general well-being, her stability, blood pressure, pulse, temperature, respiratory rate. And after that, I will assess her from head to toe in my examination, looking from the head, in the eyes for anemia, in the tongue and in the mouth and turgor for the dehydration. In the chest, I will look for any striders, anything. And in the abdomen, with the presence of a chaperone and her consent, I will assess her tummy to look for abdomen to say is there any contractions or palpable contraction or not. There is what is the height of fundus, it is a singleton pregnancy or multiple pregnancy, and I will try to locate the fetal hearts with the help of a Doppler. After that, I will look for her from the vulva, from the perineal area. In the legs, I will look for any signs of dehydration, any DVT, anything. And then I will look for the vulva and vagina. Is there any discharge, any leaking, anything? And if there is nothing, then I would not proceed for a pervaginal examination, but would like to assess that and try to establish, is it a preterm or is it a established preterm labor, or it is just a suspicion of the preterm.
Okay.
And I proceed onwards.
Right,
Okay.
okay.
Then.
Okay, so these are your examination and your history findings.
Mm-hmm. Interest to going to labor. The problem is mental downstream and fundal contractions not just power and go regular into history of Okay, from here I would, as all the investigations are already done, so the investigation which is the needed, other than that, is that to make sure that she's not suffering from any infection. So I would like to send her urine RE to get the infection, to rule out the urinary tract infection, although there is no vaginal discharge, but still. And regarding her blood counts, it's not there, to rule out that any signs of infection, to make sure that she is not anemic. The anemia is one of the reasons for going into preterm labor. And then according to her contraction, as she is only 29 weeks, I will manage her. I will inform I will make sure that I am working in a unit where the availability of where the availability of the level 3 and ICU care is available. I will inform the supervisor to make sure that the cot is available, inform the neonatologist, inform my on-call consultant. And regarding her management, I will start with her first with her permission. I will inform and offer her steroids, the dexamethasone 12 milligram, 2 doses, 12 hours apart. Also, I will offer her the tocolytics. According to the local protocol, it is etosiban or nifedipine, what is available in our local protocol. And I will try to halt her preterm labor, try to manage her if the preterm labor is by the tocolysis.
So I'm going to interrupt you here for a minute, doctor. So, okay, so what are the doses of nifedipine, if it's a nifedipine?
The doses of nifedipine is 20, the doses of nifedipine. I would like into the BNF for the exact doses of the nifedipine, whereas according to the local protocol, I will proceed with it. I'm not exact aware of the doses at the moment.
Okay. Yep. Right. Yes, continue.
And okay, and this is her finding. BMI 25. He has stopped smoking. No history, solicitor by profession. Very supportive. Cephalic, no tenderness. Fibronectin test positive. Okay, so as we did her speculum examination and there was no liquor, the os is 1 to 2 centimeter dilator and fibronectin test is positive. This means that she is in a Staphylococcus aureus is positive, which is sensitive to penicillin. So with her permission, I will offer her the dexamethasone and 12 milligram 2 doses 12 hours apart, and according to the Lotter protocol, the atosaban or the nifedipine accordingly, and give her with her permission the penicillin dose to combat with the Staphylococcus aureus positive infection with the consultation with my microbiologist and my lab and my pharmacist. And regarding the fibronectin test, as it is positive, which means that there is a chance that she may go in labor within 48 hours. So I will alert all my team and make sure that the cot is available, the neonatologist is involved. If the cot is available and neonatologist is involved, and I will make sure that my consultant is informed, the bed is available. I will continue to monitor the patient, and I will inform the patient that what is happening, that she is in a case of preterm labor, and I will make sure that she has a support. I will inform her that if she she will probably is still 1 to 2 centimeters. If she proceed more, then we may need to give her magnesium sulfate for the neuroprotection, and we already will going to offer her dexamethasone for the lung maturity for the.
Okay, that's your next information. So you are told that there is no cot available in your unit. And your coordinator midwife has actually found the cot in the neighboring unit. There is a cot available, and they're happy to receive your patients as well. Now you're supposed to make a telephone call to hand over your patient to the neighboring unit consultant obstetrician.
So I will ring the static consultation, and I will follow the SBR tool. I will inform the situation that this is a preterm labor, IVF pregnancy, precious pregnancy, 36, or I forgot her age, first slide. Her age 36-year-old, and she is contracting for 1 to 2 per 10 minutes. And her vitals are, and I inform her the situation, and then after that I will give her the background that she is vitally stable, she is not leaking, and she has no medical history of concern, she has no surgical history, and she has no acute symptoms of shortness of breath or chorioamnitis, and she has got fibronectin positive with her Staphylococcus aureus positive, which is sensitive to penicillin in the urine. I will inform the consultant that the fetal hearts are positive. I have done the CTG. The CTG is reactive with the contraction as 1 to 2 per 10. And I will say thank you for accepting the case. And then I will also give my assessments that at the moment there is no leaking, and I have already given her dexamethasone. I have already given her magnesium sulfate, dexamethasone for lung maturity, and magnesium sulfate for her neuroprotection as she's a preterm, and I will transfer her because we have no cot available.
Okay. Right. Okay.
Shall be thankful. And offer my ambulance and my midwife to accompany her till the time she is being received, and I will ask him that once the patient is received, kindly inform me back, so I am satisfied that the patient is being received and being dealt accordingly.
Okay, doctor. So right. So who is going to accompany this transfer when you transfer?
The senior midwife will going to transfer and make sure that during the transfer that her, if needed, she should be dealt like in a left lateral position, so that and we have all the things available.
Okay, I'm going to the next question. Right. So during your transfer, so once you have done all these arrangements, your midwife told you the lady has stronger contractions now, 4 to 5 in 10 minutes, and she's already 6 centimeters dilated, and membranes are ruptured as well now. So what are you going to do?
Okay, so I will halt the transfer, and I will change my decision to transfer the patient, and I will again inform the consultant and the midwife and the supervisor to inform the dealing consultant and the dealing neonatologist and the receiving doctor that we are not doing the in utero transfer, we will be doing the ex utero transfer. The patient is not in a situation to be transferred at the moment, and the patient has now gone into labor, and we will try to deliver the patient in our hospital, inform the patient, inform her support, inform her partner, and that the situation is not that she cannot be transferred, and try to manage her labor as she is already 6 centimeter dilated and she's contracting. Do her CTG continuous monitoring as she's preterm, and I'll make sure that some senior myself deliver the patient, or some senior deliver the patient, and the delivery is being attended by the neonatologist, and the baby should be taken care of, and the cot is available. Just the transferring ICU is an ICU cot is available for the transfer.
Baby, right? You have delivered the baby. Baby is born with good Apgar score, good cry, seen by pediatrician, and the pediatrician is happy with the baby, and you know, he feels there is no need to transfer baby to NICU in the neighboring unit. Baby can be left with the mother. What will you do?
Okay, I will try to assess the recommendation by the neonatologist. Maybe the weight of the baby is really good. Maybe what we have assessed, maybe the baby is not already 29 weeks. The baby is more mature than that. I will consult my obstetrician consultant on call and inform that a 29 weeker has been delivered, and the baby was advised by as per the protocol was. The cot was available in the other unit, but the neonatologist on call is not happy to transfer. So that my on-call consultant can give the input in regarding this, and if needed, that I may consult my colleague who has advised not to transfer, the reasons for not transferring, even if the baby is healthy, just to make sure that the baby is in the good health for the first 24 to 48 hours as the baby is preterm. So risk of infection and regarding to his prematurity is very important. So we will talk to the neonatologist consultant on that day, also pediatrician on that day, and they are the one who will decide that it should be there or not, and I will involve my consultant in this. That by my thinking, the baby should be at least under observation for 24 to 48 hours.
So we will stop here now. It's been much over the time. Okay, so let's just start from the last point. The baby with a pediatrics think that, you know, we don't need to transfer. You will speak, you know, and there is no, there shouldn't be any doubt whether the baby is 29 weeks or not. If it's given in the scenario, that means by the scans, by the dates, everything, it has been confirmed already, yeah? So baby is 29 weeks. Now, even if baby has, you know, reasonable Apgar score and everything, we know this baby is extremely premature, and this baby is at risk of hypothermia, severe infections, and respiratory distress. This baby still needs to be in observation in unit, in intensive care unit. So the ways this comes again, actually how you communicate with your colleagues when there is a conflict in the management. So you will first speak to the pediatrician about, you know, you will say how the baby has formed, but because the baby is premature, there can be high risk of hypothermia, respiratory distress infections. So I strongly feel that the baby should be transferred to neonatal intensive care unit. If the pediatric still feels no, you know, there is no really need at all, then you can, you know, you can tell well you feel that you should be transferred, and then you're going to discuss with your consultant as well about the transfer. And obviously after consultation, your consultant is also going to agree with the plan to transfer the baby. Okay. So this particular question is there
we will talk to our consultant or the neonatologist consultant or the peds consultant.
Your own consultant, okay. to continue with your plan of transfer. Okay, so it's like, again, you taking the responsibility of the baby as well. Being a clinician, you know all these complications as well. Although yes, the pediatric are the main specialist, but sometimes, I mean, this person may be ST3, ST4 or ST5. We're not giving much attention, even ST5. So people can make mistakes. So you need to stay. So we can't say whether the baby is responsible to the pediatrician, and if he feels, then it's fine. No. Because we also know, we are also trained in that, and we are aware of these complications. So this baby needs to be transferred. Okay, so I think you took quite long to establish history and finding. You are given a particular scenario. So starting that examination from head to toe, eye examination and all that, you don't really need to do that unless the patient is anemic and all. I mean, there is not enough time. It's an emergency situation. So first you will summarize your scenario by saying, so I'm seeing Demi for 36 years old. She's primary gravida. And I have noticed she has conceived by IVF and she's 29 weeks pregnant and she has started with these contractions. From further information, it says there's no problem in this pregnancy till so far. So I will assume that this is low risk pregnancy. Our screening and the anomaly scan and have been reported normal. Okay. And she has no medical or surgical problems. Then you're going to say, I can see the Demi is extremely anxious about this preterm labor. So first of all, I will, reassure and counsel the patient and explain what is happening. I will explain her that after the examination, we will be able to establish whether we can try to actually suppress this labor. What's going on. I will reassure her as well that although there is a risk of complications babies can have when they are born at this stage, however, there is a good chance of survival of these babies as well without any problems because of all the facilities available now and because we will be keeping baby on neonatal intensive care unit for close observation. Okay, so you need to do that as well. Yeah, this is there for some reason. Then you will say, so I will then like to get some more information to make the management plan for this woman. And in information, you need to clearly ask. It's not, I will try to, and I will try to, and I will do. You need to ask. So I would like to know, first the details of the incident, when she started the contractions, has she had any, and now you're talking to your clinical colleague, you need to use clinical terminology, you don't need to use the tummy and these words. Yeah, so you can ask, I will ask that, have the membranes ruptured, has she noticed any watery leakage or any drainage of the leakage, has there been any vaginal bleeding, did she notice any lower abdominal pain before she started the tightening? To exclude UTI, you need to say, because the infections, UTI and genital infection or even the systemic infection can be the reason for the preterm labor. So you would like to exclude all these factors. Okay, so you would like to know if there is any vaginal bleeding, any dysuria, any frequency of maturation she had, any chest infection, any cough, any fever she has. Or I will also like to exclude any DVT or thromboprophylaxis, VTE. So I will check if she has any leg swelling or any pain. So you would like to basically trace out if there is any focus of infection in the body. Okay, and then you will take the history from her, that is this the first time she has started having these contractions, and she's having that before as well, she had the episode before. And then you will like to examine the patient. And in examination, you would like to exclude signs and symptoms of chorioamnitis. So you will ask your midwife to check her temperature, pulse, and heart rate and respiratory rate. You can say to exclude chorioamnitis. You need to tell why. And then you will do the abdominal examination. So you will do first. You will try to exclude any uterine tenderness, which can be a sign of chorioamnitis, and then you will check that the fundal height corresponds with the date, the presentation of the baby. And the baby heart, you will ask the midwife actually to start CTG. So this is the abdominal examination. Then you will say, so then I will proceed to spectrum examination. And in spectrum examination, I would particularly like to notice if there is any change in the vaginal discharge, and if there is any liquor I can see, and also to see if the os has started opening already or is still closed. Okay. So these are the findings. Particularly, you need to talk what you want to see in that one. And then you will say, if I don't see any clear liquor, then I would like to do a fibronectin test just to see if the labor is imminent in next 24 to 48 hours. You will then immediately also like to check if the cot is available in neonatal intensive care unit, because it's quite premature baby. You need to transfer. Then you will counsel the couple. You will inform them that there are facilities available. However, the babies who are born at this gestation, they can have some serious complications after the birth. These babies can be at a risk of hypothermia, and you need to say, respiratory distress and infections. From our test, if we found there are any signs of infection or any evidence of infection at this stage, we will be starting her intrapartum or some IV antibiotics at this stage. And then I will explain, these babies will need long-term growth monitoring as well, because they can have the risk of learning difficulties. Then you will talk about the investigations, what you would like to do. You will take a full blood sample, full blood count, and then you need to particularly say, because you want to see the leukocytes to exclude white blood cells, to exclude any infection. You need to send CRP, and you will be sending the urine for analysis. You will do your analysis in the unit as well, and then MSU, and you will also take high vaginal swab. Okay. At this stage now, then you can ask now the examiner that what are the details of, all those questions you wanted to know. No, you need to have the information so that you can proceed further with your plan, right? So we are told there was no leakage, there is 1 to 2 contractions, baby movements are fine, no vaginal bleeding, nothing like that. And then this is the next card. You will be given her BMI is 25, low risk pregnancy otherwise. And what we can pick from here, pulse is she's slightly tachycardic, which can be because she's very anxious at the moment. Temperature is normal, which is reassuring. And then also is only 1 to 2 centimeter, but fibronectin is positive and there is Staph aureus positive. So that means you immediately need to start IV antibiotics to control this UTI. Fibronectin positive means this woman is in a threatened preterm labor. She can go in labor in 24 to 48 hours. So you need to start the management part of preterm labor. Yeah. And for that one, yes, you need to speak to the woman then and discuss about starting the steroid, dexamethasone. You should know the doses. But it was good that you didn't mess up and you simply said, I will check on the BNF or in the the protocol, the unit policy to see what doses I need to start. So you will give dexamethasone, you will start magnesium sulfate, and you will start tocopherol according to the plus policy with the dosibam or with your. And now you're going to give a ring to your consultant as well to inform that you got 1 primary gravida in preterm premature labor. And then you're informed there is no cot available, right? And then you will say, okay, so if there's no cot available, then I need to inform my consultant as well that we need to transfer this woman to some neighboring unit because we do not have the cot available. And then you will ask your coordinator midwife to check for the availability of the cot in the region. So once you get the information where the cot is available, then you will ring to the obstetrician on call for that particular unit, to that consultant, to hand over the patient. Okay. And how you hand over, you need to speak just like as you speak in the call. So you will say, first of all, I will say, I'm Dr. Disinder. Usually they actually make a phone is there. They ask you to basically pick up the phone. And there will be in some other cubicle somebody else sitting talking to you. So you will say, hello, I'm this and this. Thank you very much for accepting our patient. And the patient who I'm going to transfer, she's Demi, her name, and she's this much old, and she's 29 weeks pregnant. She came in this morning with preterm labor. She's having actually currently 2 contractions, 10 minutes. There is no sign and symptoms of choriamnitis. However, there is Staph aureus positive on MSU. I have started on her antibiotics. I have started on tocolysis, and we have started. You need to say tocolysis with what? She has been starting magnesium sulfate, and I have taken these bloods, and they have been sent off. So I'm going to make immediate arrangement for the transfer. She will be accompanied with one of our senior midwives who is well trained to deliver the babies, premature babies, and also a neonatal resuscitation of the premature baby. This is important when we said who will be accompanying. It can be senior midwife, it can be any midwife, but I guess senior midwives usually, who is well trained in the resuscitation of preterm babies. Okay. And then you will say, so I'm going to fax you the details and the notes of this patient immediately. And then obviously the notes will be accompanied by the midwife as well. Please keep us updated with the outcome of this patient's labor. Thank you. That will be your call. Now you finish the call and you are told this woman is already 6 centimeters and she's in active labor now. So what is your plan? Then obviously you don't need to again go into much details. Yeah, then all you need to do is again comprehensive and brief and precise. You will say, okay, so this woman is an active and advanced liver now, so it's not safe to deliver at this because obviously there is a risk you can deliver on the way. So I will inform the pediatric team to say that we need to deliver this baby now in the unit, and we will need the presence of one of the senior pediatrician for the resuscitation of the baby. So after the birth, when the baby is stabilized, then we will transfer this baby to the neighboring unit, and you will just inform your consultant as well about the situation. And yes, you can say you will inform the neighboring unit as well about the plan. Then you will conduct the delivery, and you need to say the pediatrician should be present, and baby will be, given the resuscitation oxygen, whatever is required. Then you need to, then you're told, okay, your pediatrician feed, baby is fine. Now that we have discussed that already, what conversation you need to take place with the pediatrician. This baby still needs to be transferred and will be transferred. Okay. So that's about how you do. So just stay, focused to that particular. Don't go into, a lot of details about, and don't discuss these patients when there is instruction discussions. When there is a particular scenario given, don't continue as a general discussion. We will do this. We will do this. And I would like to know regarding the information you need to know is also about that particular patient, and then ask for the information. What is history? What are the examination findings? They are there. Some examiners may give you the card straight away after that, but some may not unless you ask what are the findings. And unless you know the findings, you can't actually give the tailored and individualized plan for that particular patient. Yeah, so it's not generalized discussion, so just be careful about that. Okay. Next scenario, who will do that?
Hello, ma'am.
Yes, hello.
Ma'am, if the baby is admitted in NICU, when will the mother be discharged, ma'am? Till the baby is there, we have to keep the mother admitted. Or
so here in this particular scenario, you will transfer the mother as well. So mother will stay. So baby goes into unit intensive care unit, then the mother will stay as long as she requires from her care point of view. So if it's a normal straightforward vaginal birth, then after 12 hours, 10 hours or so, if there is no other risk factor, but because she has that, UTI going on, she needs antibiotics. So we will like to keep her at least for 24 hours to give her antibiotics and make sure that she's not developing any complications. And then you will discharge. So no, baby may need to stay there for a few days or even weeks. Obviously, we cannot occupy maternity bed for that long. But they will stay as long as we require from the maternal indications. Otherwise, she will be discharged even after a few hours. So what basically happens is they can actually, so there is a family visiting room, and there are those rooms available on the neonatal ward where they can actually stay. They can come, they can actually spend a whole day over there. But it's not like proper ward and bed occupying situation. So no, we don't need to keep the bed occupied by the mother. Okay.
ma'am, can you please show the number 5 slide?
Number 5 slide. That's the one?
Next one.
Okay, before was this actually. And then you have this.
Ma'am, is Nefidipine the first line drug or Etosiban, ma'am?
It depends upon the units. Mostly here is etosiban is used, but then the right thing to say is according to the unit protocol. Some use nifedipine and some etosiban.
What about dexamethasone and betamethasone, ma'am? Which one is preferred there?
No, it's dexamethasone.
4 doses. Okay. Okay.
Okay. Right. So right. I need the next candidate now. Who is going to do the next scenario? Right. So it can be anybody from Saturday and Sunday group both. So Sundas asked about the intrapartum antibiotics. Yes, Sundas is going to be penicillin, and you will continue like intrapartum protocols. You will be giving that every 4 hours till birth. And then you can, because of the UTI, you will continue, but then you can shift on oral antibiotics if the mother stays afebrile till then. Okay, so right, so who is next then? Dr. Rahab, are you with us? You want to do the next scenario? No, Dr. Rahab is not with us. Dr. Radat, I think he's not there either. Okay, I'm gonna go to Shandana.
Yes, ma'am, I'm here.
Right, okay, so this one is for you.
Okay. Oh, Dr. Safia, I'm not quite well prepared for CTG. If someone else can
Okay,
do it.
that's fine. We can ask somebody else to do it. So,
Thank you.
is Rabia here? Rabia Kuso?
Yes, hello, Dr. Safia, I'm here.
Okay, this is for you, Rabia. Then.
All right.
Take to prepare.
Do I have the CTG trace here? Okay.
Okay, this is your first 2 minutes.
Yeah. Hello, I'm Rabia Dusty5 and you are?
I'm Jade Molly.
Okay. Hi, Jed. How are you doing?
I'm okay, not too bad.
All right.
The midwife asked me, she called me to see the CTG of this lady.
Yes.
This is primary gravida, 32 years old and spontaneous labor. But to be honest, I don't know much about CTGs at this stage, so I have no idea what to do with this patient.
All right. No worry, Jed. I'm just here. I will go through with you the CTG and we'll have the assessment of this CTG according to the patient's risk factor. And then I will let you the abnormalities that is being detected with the CTG. Would that be okay with you? Yeah.
Yes, that's fine, doctor. Yeah.
Yeah. So before that, have you undergone through any CTGs previously?
Well, I have seen,
Mm-hmm.
I have the simple one, but this particular one, it looks quite complex to
Mm-hmm.
me, to be honest. I couldn't make any. So I do have some idea, I have idea about the CTGs, yeah.
All right, that's good that you have some basics knowledge about the CTG. So, Jed, what I'm going to do, I'll assess this CTG which is in front of us, and we'll do the risk assessment of this patient, and we'll make sure that you understand the basic concept of the CTG and the parameters that is being looked, and then we discuss the management that has been based on this CTG. Would that be okay? Yeah.
Okay, doctor, yeah.
All right. So, Ajad, you see that this is a patient CTG who's being priming gravid, and she come to us in the labor at 40 plus 6 weeks of gestation, the spontaneous labor. So, basically, Jed, a CTG is an electronic trace of the fetal heart rate to just check about the baby's well-being. So, if you can see in front of us, the CTG has 4 parameters. And first of all, if you know what is a CTG of the patient, we should have the trace, which should include the patient's name and the date, the full name and the date, because this is identification, and date is very important because CTGs does contain some the litigations. So, but as you can see, this CTG which is in front of us does not show the name. All right. So if you go with this CTG with me on looking the CTG JAD, we do have the parameters to assess, which is the fetal, the baseline heart rate, variability, accelerations, and decelerations. So do you have any idea about that?
Yes, I know about the baseline. It should be, I think, between 120 to 140, and there should be accelerations, and there should not be any deceleration for normal CTG. Yeah.
Yeah, that's good. You're quite right in saying that. But before going to the CTG, we do have the parameters which is called the Dr. C Bravo Do. We have to determine the risk in this patient as she's priming gravid and she's a low risk, so the risk has not been there. Just a CTG trace of labor, and the C is for contraction. You can see the above shows the in this trace the above graph shows the fetal heart rate, and below you can see here. Can you see with me? These are the contractions. So in the 10-minute contractions with the CTG, you can see if you go with 2 broad lines from this broad line to this JAD, so this patient is having some contractions almost 1, 2, and 3 in a 10-minute trace. Can you see with me? Right?
Yes, doctor.
Yeah, and for in the above you can see the baseline of this CTG is normally the baseline is 110 to 160 beats per minute. It does vary with the gestational age, but usually this is a parameter which is a standard. But in this CTG you can see that the baseline falls at the 180 beats per minute. So this shows that there is a fetal tachycardia, and this whole CTG is of 20 minutes. So between 2 broad lines, the 10 minutes distance, and we do have the 3 broad lines, so this means the CTG of the 20 minutes. So what is the baseline as I told you? It's 180 beats per minute, which shows a tachycardia. Are you following me?
Yes, doctor, yeah.
All right. And the variability normally should be between 5 and 25 beats per minute. And small box shows that this is equal to the 5 beats, but we can see this has been reduced. It's almost less than 5 beats. So we can say the variability of this 20 minutes trace of CTG is reduced. And the acceleration, the third parameter is acceleration, which is the heart rate, the rise in heart rate from the baseline, and it should be 15 beats per minute and for lasting for the 15 seconds. So in this whole CTG trace, we do not find any acceleration because the heartbeat is not going up for the 15 beats, and 1 small square is equal to the 5 beats. Am I clear so far?
Okay, yes, doctor.
All right,
Yes,
and
doctor.
the fourth parameter is this, in Dr. C Bravo Do is D is to determine the deceleration, which is the fall in heart rate for 15 beats per minute and lasting for 15 seconds. So Jed, here you can see this CTG shows the deceleration And we do have the decelerations in the form that there are 3 types of the decelerations: early, which is just mirror image of the uterine contraction, and the late deceleration is when the uterine contractions stops and they start falling the heartbeat. And the third one is variable deceleration, where the uterine it does not correlate with the uterine contraction. So in this trace you can see this is a deceleration. You start from the go from the left to the right, and this heartbeat is going down with the uterine contraction. And when the uterine contraction stops, the heartbeat comes towards the baseline of 180. So these type of decelerations are called the early deceleration. Am I clear?
Yes, doctor. Yeah. Yes,
Yes.
Dr. Rabia, you're
Yes.
clear. Yeah.
Yeah, so this CTG looks like a suspicious stress because we do have the certain criteria. On these basis, we say that it could be the normal, suspicious, and pathological. So 2 parameters are being abnormal. So the parameters would be there's a reduced variability and the decelerations. So if all the parameters are normal, this is normal CTG. If the 2 parameters are non-reassuring, as we can see here, there is a tachycardia and the reduced variability and deceleration, so it is suspicious. And then when it prolongs for more than 50 minutes, so we can label this CTG trace as a pathological. All right,
Okay.
am I clear so far?
Yes,
Yes.
doctor. Yeah, yeah.
So
What we need to
yes.
do for
So
this
what?
lady.
Yeah. So this is a suspicious stress, and we have to take the step here. We have to assess this patient as a whole. As we know that this is a low risk patient, but we need to take step in the form that we have to assess vaginal examination to show to see that what is the Bishop score. And if it's fully dilated, so we have to add the delivery in the form of the instrumental delivery or the cesareans. If she's not been fully dilated, we can go for the fetal certain measures in the form that we need to rule out why patient the fetal heart rate is showing tachycardia. So we have to check the maternal pulse, temperature, because sometimes if the mom's pulse is raised, the fetal tachycardia can occur. So need to hydrate the patient, change the position, keep the left lateral, and start the IV fluids, and then continue CTG monitoring. Here you have to involve your senior consultant, pediatricians, anesthetist, and also the your senior midwife in the decision making. And also inform the patient that you do have some concerns about the baby. Am I clear so far?
Yes, sir. Yes, Dr. Rabia. So, okay. So, we need to do fetal pulse something for this lady then.
Yes, and the next step, if it
Go
is
ahead.
she's 4 centimeter dilated and CTG is and the delivery is not imminent, then we'll go for the fetal blood sampling to check the pH of the baby, and then our next step would depend upon the fetal blood sampling result.
All right. Okay. And how we interpret those fetal pulse something results, doctor? Then.
Yes, so what happens in the fetal blood sampling? We do have the parameters just like a CTG, which we look for the pH on the fetal blood sampling. It's a normal pH is 7.25 or above, and the borderline, which if pH is normal, you have to continue with the patient CTG and monitor it continuously. But the pH is if between 7.21 to 7.24, and this is a borderline pH JED. For that, you have to again inform your senior obstetrician, your nephrologist, the mom, and then you have to continue to take the second sample of the FBS fetal blood sampling in 30 minutes. And if
Okay.
the fetal blood and if the fetal blood sampling is abnormal, which means that if it is 7.2 pH or below, then this is a time we have to deliver the baby. Because if we do not have to deliver the baby, the baby might go into distress, and we might lose the baby. Am I clear?
Yeah, doctor. Yeah, right.
So in this CTG, we are going to start the conservative measures. As I told you, check the mom's temperature, pulse, IV hydration, and we have to inform a consultant, pediatrician, and also involve the mom as well.
Mm-hmm. Okay.
Any questions so far?
No, that makes sense to me. Yes.
All right. So we are just going to start it and just involving our consultant in this decision, and we have to document each and everything on the patient's note. Okay. Thank you so much.
Okay. Thank you. Thank you. Bye. Yes, good. Well done. Nicely done, Rabia. Yeah, so in the beginning, you need to take again, you need to imagine you are on the floor and this patient is there. So the way you speak, you need to keep doing that as well, that you are aware of the situation. There is urgent intervention needs to be done, right? So you need to express that at the beginning as well. I know you did later on by saying we need to examine this woman now and then accordingly, but establish that in the beginning as well to say. So when you come in to say, no, she's your colleague and she's doing duty with you today, so you should know the name, right? So for this particular colleague, it's not very good to come in and just ask the name of the, my name is this and what is your name. No, just call from the name. Hi, Jane Morley. I'm Dr. Rabia, University 5. And then you can ask her like, okay, so you're right. And then say, right, okay, so you wanted to talk about this patient with me. And then wait for information she gives you, yeah? So she says, yes, the midwife called me and she wanted me to read this CTG and I have no idea about this. And this woman is this. And then you actually start teaching her CTG. You need to take more information about the patient as well. So it's not only that you will say, you need to do that assessment as well. Is there any other risk available? Yeah. So you will ask her then. So once she's given you 32 years old and she's 40 plus 6, so then you need to acknowledge here that she's 6 days post-date. So you say, okay, so she's 6 days post-date. And does she have any other risk factor in the pregnancy? Has she been okay? Any hypertension or any problems with the anomaly scan or any other risk factors of the mother or the baby of this particular pregnancy? Just ask from her. And then you say, when she says she has given me this CTG and I have no idea particularly to do this, then you need to say, yes, that's okay, and I'm glad that you have called me to see this patient, and I appreciate, it's really important that, when we're not sure about anything, or with the higher risk patients particularly, we always discuss with our seniors, colleagues, and take their input as well before we make any final plan of management. So it's absolutely fine, don't worry, so what we need to do is, because from the, you can overall, the CTG, what it's looking like. So you can say overall, you can say this CTG is concerning. At this stage, at least you can say that this CTG looks quite concerning to me. So we need to actually urgently do some interventions. So what I'm going to do, meanwhile we get the, the preparations, then I will, briefly explain you as well how we interpret the CTG. All right. So and then you will say, so I will explain you in a minute, but we need to put this patient into the left lateral position. And then, and continue the CTG, maybe to start her some fluids. And then we need to do the vaginal examination to see what the dilatation is. So you're managing the patient at the same time as well, right? Now, at this stage, you can actually ask her, so have you examined her, or the midwife? She told you how much dilated she is, right? Then you will say, okay, so on this particular, how you do it, then you can start, you can say, I hope you have attended some of these drills and CTG interpretation training, so there are like we use is like Dr. C. Bravo, so define the risk. First, just to see is there any other risk, in the pregnancy, which we know in this particular woman, there is no other risk other than that she's 6 days post-date. And then you need to, then you can say, so C is for contraction, just write on the paper basically that, and say C is for the contractions, and then just tell her, yes, obviously when you have the CTG trace, you can mention, but you need to tell what we mean by 10 lines. So between these, where these numbers are given, between these two number compartments, there are 10 of these, yeah? So you can say, so these lines, they are for like 1 minute. So they actually, there are 10 columns you can see here. So it's like 10 contraction. You need to see first how many contractions in 10 minutes time, because sometime if the patient actually is, the uterus is hyperstimulated, she's hypercontracting, that can also cause fetal distress and fetal asphyxia or hypoxemia, because every time during the contraction, obviously there is some interruption in the blood flow from the placenta to the baby. So that's why it's important, yeah. So you say, but it's fine, she's having 3 contractions in 10 minutes time. And then you need to come to the parameters of the CTG, and there are 4 elements you need to look for that. So baseline, and then could ask her, do you know what the the normal baseline range is? So she may tell you, then you can say, okay, so in our patient, she's actually tachycardic because the baseline is about 175 to 80, is touching to that. And the next one you need to do is then look for if there are any acceleration, and the acceleration is actually that the fetal heart rate should go above the baseline at least 10 to 15 base 10 to 25 beats, and it should stay for 10 seconds, 10 to 15 seconds. Just keep that criteria, and from the look of that you can say, so we can see in the CT there is no accelerations. And the next thing comes is, do you need to check for the variability of the heartbeat? And this one small box actually represent 5 beats, where we can see this line is almost flattened, which means variability is extremely reduced. And after that, so that's the second abnormal characteristic of the CTG. And then the deceleration. So you interpret deceleration in relation to the contractions, and then you said there are 3 different types of the decelerations. If the depth of the deceleration actually coincides with the peak of the contractions, then they call early decelerations. And early decelerations on their own, just alone, are not taken as abnormal or pathological, because they may present as the cord compression. However, in this particular situation, this deceleration is very deep. She's having, although to recover it quickly, but then the variability is extremely reduced, and the baseline is tachycardic as well. So because of the presence of these 3 abnormalities, the CTG actually becomes suspicious, which means we need to do some immediate intervention. So are pathological, so we need to do some immediate urgent intervention. So the urgent intervention is, and then you can explain as well, because this actually explains these decelerations can reflect the baby's respiratory distress. So that's why it's very important that we do something either to deliver this baby. If the delivery is imminent, like if she's fully dilated already, then we will need to actually immediately deliver this baby. By using, depending upon the station and the position of the head, then we can either use the instrumental delivery, or we may need to go for cesarean section. And then you need to ask basically, so what is the dilatation, cervical dilatation? Have you examined this woman, or has the midwife told you? You need to behave like as you are actually managing this patient, yeah? And then if you say, yes, the midwife told me she's 5 centimeters dilated or whatever, then you can say, okay, so that means we need to actually do the fetal blood sampling. So have you seen fetal blood sampling before? And then you can say, okay, so let us the midwife to bring us the the instrument, everything, the kit we need to do the fetal blood sampling, and also check if the fetal blood sampling, the gas analyzer machine is working. And then you will briefly tell her about the you will say, I will in the left lateral position, and then when I'm doing the fetal blood sampling, I will try to demonstrate to you as well. However, briefly, we will actually take sample from the baby's fetal scalp skin, and then we will analyze that to check the pH, and also to check the bicarbonate levels to exclude metabolic acidosis. And then further plan will depend on the findings which we will have. Where is that gone? I did have a slide actually to interpret. Right. Misplaced the slide somewhere. Anyway, so you guys know, you can then tell that to interpret this, we need to look at the bicarbonate levels and also on the pH. And then you can say, obviously, if the pH is 7.25 or more than that, that's reassuring. That means the baby's, the baby is not in hypoxia, and we can actually observe this CTG for further 1 hour. And we can continue by making these left lateral position starting in the fluids, and then we will need to repeat, and if the CTG recover and become normal and reactive, then it's fine. We won't need to do anything further. But if the CTG remains the same, then we will need to repeat fetal or something after 1 hour again, then to establish again the fetal hypoxic status. If then you tell about the borderline, like if it is from 7.20 to 7.24, then that means the borderline. That means like the baby is actually, the oxygen saturation is compromising, but it's not life-threatening at this stage. So after these conservative measurements, we can observe the CTG for another 30 minutes. And if it did not recover and become reactive, then we will repeat the fetal blood sampling again and then take the decisions accordingly. However, if it is below this level, 7.20, that means we immediately need to deliver this baby. We won't really waste any time to do fetal blood sampling then. And depending upon the dilatation of the cervical dilatation at that stage, if she's fully dilated, we will do instrumental trial of instrumental delivery. And if not successful, to cesarean. And if she's now fully dilated, basically we will take her and do the emergency cesarean section to deliver this baby. Then you need to continue to decide. So once this baby will be born, it's very important that we do take the sample from the cord to do the gas analysis as well. Okay, to compare with our intrapartum findings of the results. So this is very important. If you have done fetal blood sampling at some stage or the CTG has been abnormal, or you have done the instrumental deliveries, then you always take the cord blood for sampling as well for gas analysis. All right, it was fine. You did nicely. I just wanted to make it a bit more, just the way you describe. Give the impression you are aware that we actually are dealing with the patient. So this is type of teaching which you are doing alongside the management of the patient, right? So it's not dedicated or protected time for teaching where you can check. You know, those are different things. Do you know that? I will tell you this and then you will tell me back, and are you okay with that now? It's the kind of where you just go along, you are managing the patient at the same time, and at the same time you're explaining your juniors what you are doing. Okay, happy?
Yes, thank you, Dr. Safia.
Right. So we need to go to the next station now. And who wants to do the next one? Atya has done Shandana and okay, no, Shandana hasn't done. You've done Shandana. I'm gonna give this next one to you. Yes, hello, Shandana.
Hello, Dr. Safia. Ask one question.
Yeah.
Dr. Safia, sorry, I was I just see that the CTG which you show. So this is the early deceleration.
Let me go back to the CTG image first. Yes, this is early decelerations. Because the depth of neither of the deceleration is the same time when there is a peak of the contraction. However, the interpretation and management of this early deceleration will be different because it's deeper. Yeah, it's going up to 80 beats below 100 beats. And there are other few pathological because in this particular scenario you won't be able to go into the details, but basically if you see this CTG, these decelerations are lacking shouldering as well. Yeah, so shouldering is like this. When the deceleration starts, it goes like in a slow way, it goes down and then it creep up that as well. If the decelerations goes like straight like this and then it's recovering with this shouldering as well, that means basically it's a parasympathetic increase in the heart. So this baby is basically already getting severely compromised. Okay, but still this will be entitled as the early deceleration. However, this is complicated. When we say complicated, variable decelerations, complicated early decelerations. So you will call it a complicated early decelerations. So complicated means when there are other abnormal characteristics present as well, and you need to actually take that as a pathological CTG. It depends upon the quantities as well.
Okay, thank you so much.
Right. Right then. So, right, who was next then? Hello, Shandana. I can't hear from Shandana. Okay, so next, who else is from this group? Sama?
Hello. Yes, Dr. Safia.
Yes. Hello?
Yes, Dr. Safia, I'm here.
Right. And this one, okay, this is for you then. There are more rooms as well. So when you have noted these 3 rooms, please let me know so I can take you to the next slide.
Actually, I don't think 2 minutes will be enough to finish all reading all rooms. So we can go room by room, then we read at the same time.
Okay. Okay, your 2 minutes are over now anyway. That's fine.
Okay. Room number 1 is a case for trial of scar. She is 39 weeks and also with prom since 24 hours. So this patient needs to be examined, vaginal examination, because her all vitals, blood pressure, CTG, glycol, everything is okay for her, but we need to know about her vaginal examination to know about her bishop score. I can see also patient doesn't want any medical intervention, but we have to explain to her that she is at high risk. She is a high-risk patient because of previous cesarean section. She needs continuous CTG monitoring, and she needs to put a cannula and for Grove and Safe. And what is it? Yeah. So and also to start antibiotic because she is membrane rupture more than 24 hours now. So what we'll do for this case is to she needs to put a cannula, to put to Grove and Safe, and put in CTG and continuous CTG to check her vaginal examination. And we can be monitored by midwife right now. Then if any scar tenderness, any problem in her vitals, any signs of pending rupture, any bleeding, the midwife can update me right now. So it is non-urgent case, can be managed by midwife. Okay. Second room, yeah, second room. Admitted at 2 a.m., 36 years, para 2, 35 weeks. Dichorionic diamniotic twin pregnancy at 35 weeks, comes in spontaneous labor. This patient is progressing well in the first stage. And first twin is the vertex, engaged, clear liquor, CTG reactive, twin 2 transverse, CTG coming up to second stage of labor. So this patient, we need to know about her vaginal examination. She's coming about second stage, so we'll ask the midwife to look after this case, to monitor her, and in case of and when reaching second stage, to inform us, because this patient needs to be delivered in theater. So right now it is not emergency, but this is semi-urgent case, needs to be seen soon, not later on. So to be prepared for transferring to a theater. So I will go for this patient, I will go myself, or according to the labor room situation, if needed, I will inform my consultant. And I'll make sure that IV line and everything blood is ready for her, and anticipate as well, and I will do active management of second stage. It depends on the patient progression and second babies also. If not rotated or anything needed to be done. So it needs to be ready for shifting to theater. Room number 3. Okay. Delivered forceps by 4 hours. Male, 4.6 kg, pph, large second stage episiotomy. So this is an emergency case. A case of PPH after difficult delivery or instrumental delivery of a big baby and extended episiotomy. Her vitals, she looks in shock because her blood pressure is low, and pulse tachycardia, hypotension, and oxygen saturation is low. So all her vitals telling that this patient is in shock. So needs immediate attending for this patient. I'll call for help. I evaluate the patient and I will explain to the patient everything that we need to examine her under anesthesia. So we'll prepare this patient to be shifted to OT, and I will inform my consultant also as well.
Okay.
Because we need to know about the extension of the tear and to repair the tear in the theater. Yeah, we need to go to the next. This is an emergency case. I need to go myself. Room number 5. 33 years, 31 weeks with abdominal pain. Contraction, very anxious, cervical, suture, etc. Yes, the case of preterm labor at 31 weeks with cervical cerclage in situ. Comes with PV discharge, her abdominal examination, long lie, PP cephalic, uterus CTG reactive, and uterus not tender. So this patient, I need, all these findings were at 2 a.m. So we need to know what is the update of the patient. Means I can send one of my ST. I don't know who was me, Dr. Sophie.
Right?
Who is with me?
Right. Okay. So you got your consultant on call. You can call NSCT 65, and then you have a consultant NSCT 65. You have your SP3 with you, and then you have a midwife coordinator and 5 other staff midwives.
Okay. So this patient needs to be seen by one of the midwife. Can go and PV for the case and update if it is there is any cervical dilatation, or if any the suture is under tension, and if she is stable and no contraction, so can just monitor the patient and give her as may be evaluated already at 2 a.m. So we need to re-evaluate again to check for contraction and PV findings, and to check if she is receiving her corticosteroids and to check PV for the suture, if it is under tension, needs to be removed or not.
Mm-hmm.
And to check her CTG again and to update me. It's a semi-urgent case, and one of the midwife can assist the patient and update me. So I will go for room 6.
Mm-hmm.
The case arrived at 3:30 a.m., 38 weeks, 26 year, para 1 normal, uncomplicated antenatal care, cervical dilatation 2 cm near clear liquor, contracting 2% undiagnosed, extended breech presentation. So this case needs to be seen by the ST3 and to check if because she came at 3:30, maybe her cervical changes become more advanced now. And I will check also if already explained to her the options of vaginal delivery or going for cesarean section. If she wants cesarean section, means I will make sure that she is ready and IV cannula and the blood group and save and everything ready to be shifted for cesarean section. And after finishing my PPH, if she's still not advanced in labor, means she can wait after finishing. But if she is advanced in labor, means we have to shift for cesarean section.
Okay.
So this is urgent case according to the PV finding right now, because this is all PV. This finding was at 3 a.m.
Okay.
Case room number 7, coming in ambulance. So this case is coming in the way, looks preeclampsia, severe headache, and some vaginal bleeding. It seems as placental abruption. So we'll assign one of the midwife in room 7 to wait for the patient. Which means when she comes, she will start initial resuscitation for the patient and will attend accordingly and will manage accordingly.
Okay.
Room 8 arrived 7:30. 42 years, 38, blood pressure is high, rupture of membrane meconium, staining not contracting, longitudinal PPH, CTG is reactive, urine is awaited. So this patient is hypertensive, rupture of membrane meconium, but CTG is reactive. So this patient, it is not an emergency case, semi-urgent case. We can ask the midwife to start preeclampsia protocol, and according to the urine result, if it's still preeclampsia, we can send the blood, preeclampsia blood, and we'll ask the patient about any symptoms. We'll look for any signs of impending eclampsia accordingly. And he needs to deliver, because meconium is there also. You need to do PV to check to evaluate her for either induction, or if she is already in labor, to monitor her continuously. She should be under continuous monitoring. So we'll initiate preeclampsia protocol and monitor the patient. This is semi-urgent case. This is urgent case, can initially attended by midwife, then my ST3 can see her afterward. So
Okay.
the most urgent case is that PPH. I don't know which room it was.
Sorry.
The PPH is the most urgent case. Number 3. Then the undiagnosed, then the room 2. And I will call my consultant. So I will attend myself in PPH. And when my consultant comes, I can hand over the case and will go for twin. This room number 2. And the other slide, please. Next slide. So afterward, room number is that undiagnosed breach one. Yeah, room number 6.
Okay. Yeah. Okay. That's fine. You need to you told about the midwives and stuff previously. Yeah. Okay. So that's fine. So something I repeatedly tell you guys is that you must ask, basically, you know, instead of saying I will ask what the findings are, ask that person. You didn't ask me to provide you partogram or the CTG for any patient.
In
and
most of the patients, CTG written
is written over there, yeah. But you need to know the correct ones as well, what the dilatation is now and what's going on. So always make sure that you do get them from them, like room 2, these twins. The examination they have, like, I mean, there's no findings given for the cervix, how much dilated their cervix is, yeah. So we can't really decide.
I asked I told according to PV, because she is about to be in second stage, means she is imminent to deliver now.
Yeah. So always ask them. So can I have the partogram and the CTG for this patient? Yeah. So they will give you basically, and they will tell you then and there, this is the cervical dilatation. So yes, you can do this way. That's the best way basically to do, because otherwise sometimes you just jump from the rooms and at the end you can quickly tell the priority. So room 1, plan was fine. She's 39 weeks, she's on 24 hours on previous cesarean section. And she's having, you know, some tightenings now, and temperature is fine, respiratory rate and CTG is reactive, clear like a training. So all you need to do is here as well, you need to just ask your midwife to examine her. And because again, put on the continuous CTG, the rupture membrane is more than 24 hours by now, so she will need to start IV intrapartum antibiotics for this woman when she's in active labor. So you don't need to do anything active at this stage to stimulate this labor now further. All you can do, you can ask your midwife actually to examine, but you need to know and you need to exclude the signs of any choriamnitis before we decide to leave her at the moment. So you will say that I would like to know her pulse, temperature, and blood pressure, and I would also like to examine for any, you know,
so everything actually written. All vitals are written normal.
Yeah. So but what happens is, like, it doesn't tell us they are recent or they were at the time of admission and when they were. Yeah. What important is, what I'm trying to tell here is that before you decide the plan of this room, you need to establish few things. You need to exclude the risks. Yeah. The risk in this particular woman can be any active signs of choriamnitis and plus like what the dilatation and stuff is. Yeah. So if they're just done, that's fine. I mean, when you ask and they said this is just done, then it's fine. You can say, okay, so there is no risk of choriamnitis here. And then you can say, okay, so CTG is fine. We can actually, you know, leave her at the moment. I wouldn't like to further stimulate the labor at this stage because we have some emergencies going on. Then your room 2, again, they are
Sorry, Dr. Safia, what is meant by she doesn't want any medical intervention? What is meant by she doesn't want?
So when that mean basically they're trying to say she wants to basically go into spontaneous labor and then stay spontaneous as well without any, but obviously we need to speak to her and tell afterwards if we need to stimulate this labor, we can't wait much longer. Or once she's already, you know, has started dilated, then we will need to stimulate maybe with oxytocin, or if she didn't make progress, then we may end up taking her to cesarean section. So your midwife needs to just explain her at this stage, and you will just let her wait till you deal with your acute emergencies. But we need to speak to her about the possibility that if it didn't progress very well, or if there are signs of fetal distress, we may end up doing the cesarean section.
So we have to tell about that because she is already prom and needs to expedite the delivery.
Yeah, so you know, if she's tightening as well, then obviously we can't keep sitting on her for about 48 hours or so, like just waiting that the contractions will get stronger, because we need to take some decisions. So from that one, at the moment, yes, if it's progressing uneventful, that's fine. We will keep it, you know, on interventional as long as it is safe for her and for the baby. Yeah, and then you will. Room 2 for the twins again is fine. Yes, the first one is cephalic, and the second, obviously, we can do the maneuvers if we needed to. So yes, you can allow, just continue for the, just watch the progress, number of contractions, CTG is reactive. And then you need to know here though, I will ask, can I have the partogram, and I would like to know how much dilated she is so that we can plan it accordingly, as the twins needs to be delivered by the ST5 or the consultant. So we would like to know how much she is, and they will be delivered in theater as well. Because the twin 2 being in transfer position, we may need to do the
Therapeutic version or
therapeutic version, or we may need to then according to we may need to do the Caesarean section. Room 3 is very easy and simple. You need to say, from looking at the amount of the blood, you need to say some major PPH. This is the most urgent and emergency patient. I will initiate the protocol of major PPH. So I will ask them to call my consultant and anesthetist, the senior midwife coordinator, and the other staff which is free to come and attend this woman, right? And then you can say, okay, so it's a forceps delivery, and the baby is 4.6 kg, so they could be they can be either atony can be the reason. It says large second-degree episiotomy, so it could be some tissue trauma bleeding as well, right? So you need to approach, and you need to take that ABC approach. So you will say, first you will say if the patient is conscious and her airway and breathing is normal, you will then start that immediate protocol. In which obviously she will be put on a continuous monitoring. For the pulse oximetry will be attached, continuous monitoring for pulse and blood pressure. You will start the oxygen, and when your anesthetist come, obviously he will take the side, the care of that side. Then you need to ask one of the midwives to actually take the notes and record the events. And then you will ask one of your colleagues to put 2 wide IV bore cannulas if she hasn't got one already, and take the bloods for cross match and for full blood count, UNEs, LFTs, coagulation profile. And then you, at the same time, you will say that I will examine the palpate the uterus to check if the uterus is well contracted. Then you will do the vaginal examination to remove any clots from there, and also if there are any uterine clots which can be removed. And then you need to say at the same time, I will explain to the patient as well what is happening, and also explain that we may need to transfer her to theatre if the bleeding didn't stop. Then you can actually mention here by saying if she has a large episiotomy, which was sutured, repaired, obviously that can be quite painful as well. So patient you may not be able to actually do the proper examination if the patient feels quite a lot of pain. Then you may need to actually transfer her to theatre even for the examination, to put her under general anesthesia so that you can do proper examination. And also explore if she might be bleeding actually from that repair. There might have been some bleeder over there. So there is a likelihood, but you need to say that if she couldn't tolerate the examination, then we might induce that anesthesia even for the examination and anesthesia. Then just follow the protocol. So you need to say you will ask them to alert, speak to the hematologist as well, arrange for transfusions, 4 units of blood from the blood bank. Right, and then just continue with that protocol. So if atony is the reason, then you need to say if she's bleeding from the episiotomy, then obviously you will secure the hemostasis and you will repair it. But if the atony is the reason, then you will just continue with that. So she has oxytocin already. If she's normotensive, then you will give her ergometrin and then you start carboprost as per protocol. If she doesn't respond to that, then you will give her sublingual misoprostol. If that doesn't work, then obviously, hopefully by that time your consultant will be there. And can everybody put their mics off, please?
So Dr. Safia,
Sama mic that is making the noise, no? Background noise.
Okay.
Dr. Safia, so I have to tell everything in details, because if I tell that like that, I won't finish all the cases.
No, not in detail. Just mention by saying this will be done. If this is episiotomy, then we will repair it. If not, then we see atony, that procedure you will find. you will
And as
follow up.
regards the place of examination, means she is already on epidural. So first, initially, I will examine her in the room itself. I will do initial evaluation. So if
So the uterine examination for tone and also the vaginal examination, that you will do immediately. So that's why you need to say that if she can, if she can't tolerate that examination, and if you feel pain, then you may transfer her to theater for the GAR according to the anesthetist. Okay, so your anesthetist will actually then take care of the fluids and the blood. You will deal with the surgical or whatever the interventions you need for to control the PPH, and your consultant will be there. And then you will say, obviously, depending upon this PPH needs to be controlled according to the reason. And if the H1 is the reason it doesn't come under control after certain time and by years, then the decision for hysterectomy will need to be taken, and the other consultant will be involved in that decision as well. So you're just basically giving the salient important points for that. Then your this room
Doctor, in
is.
this, once the consultant has arrived, we will leave the case and go to the other room, or continue in the same case and the consultant will take care of the other cases.
You don't particularly need to say that that I will leave and go, because at this stage we haven't identified any other emergency for the time being. Yeah. So when there is a PPH, you need maximum people to attend that. So you still are fine over there. Now you review your room 5, and the room 5 says this lady has been here since 2 a.m. and it's 8:30 now, so it's about 6.5 hours. 31 weeks. So I would like to actually ask this from the ST5, who I'm taking that over from. So in your circumstances, from the examiner, you need to ask. So, so what was the examinations on the speculum? Is she dilated already? Has the contraction subsided now? Has she been started on toccolysis, and has she been given the dexamethasone? So you need to just make sure that. And you need to ask what was the speculum examination as well, like PV discharge, was that just a discharge, or actually there was a LICA, and was there any dilatation of the cervix, and has a full blood count and CRP sent, and high vaginal swab. You need to ask as well then what was the fibronectin test, has that been done, or did she have an scan for the cervical length, because that you need to know to establish whether she's an imminent paper or not. And then current situation of this tightening, it says like she was having occasional, so abdominal pain. So you need to know as well whether urine analysis clear. So she may not be in any emergency at all. I mean, maybe they have been settled on now, and this no UTI, no choriamnitis, then we can just send one of the midwives to just monitor her. Room 6, 3:30. So she's here for 5 hours as well now. She is 38 weeks, spontaneous labor, uncomplicated care. There was cervix 2 centimeter. Draining clear LICA and undiagnosed extended breech presentation. So then that means we need to then ask, like when actually she was diagnosed with the extended breech presentation, and since then has the previous team, the consultant or the ST5, discussed the mode of delivery with this woman. Because obviously when they would have found it, they would have explained it to the women, and they would have, unless they say, no, she has the examination just, this 15 minutes ago, and in that examination, we have diagnosed that she's a pre-presentation. So then you need to say, that has she been discussed within when she was diagnosed initially with, has she been discussed with, and the mode of delivery has been discussed with her, and what she has chosen. Is she wanting to go for a vaginal birth? And then you need to also say, and have the other risk factors are the contraindications of the breech vaginal. If they say yes, she has chosen for vaginal birth, then you need to make sure that those being excluded and discussed. So this is information again which you need to take from ST5 before she goes. Yeah, so you're asking that from the examiner. That is not hyperextended, neck, and what is the weight of the baby, and everything else is fine. So room 7, obviously somebody coming in, we don't have any further information. So you're going to, you will say, I'm going to allocate one of our senior midwives for this lady to receive when she arrives, as she has a severe headache and some vaginal bleeding. So we do not know if she's in preeclampsia or she's in a, abruption or in some APH, what is going on. So this will be a potential emergency as well. So I will, allocate one of the senior midwives to receive the patient as soon as she comes, review her notes by that time to find out the placental position and her previous antenatal care record, her blood pressure, any protein in urine. Okay, so you will ask, like, once she arrives, then the patient, she needs to inform us, and if she has a protein and if she's not bleeding much, then she needs to initiate the protocol of severe preeclampsia. Room 8 is somebody again where blood pressure is high and she's 39.2 with meconium and not contracting, so she's not in labor. Cephalic, all else is fine. Our concern here is she actually preeclampsia, right? So it's fine for you to ask at this stage that is that the first time her blood pressure has risen, or she's already diagnosed with preeclampsia or PIH, and is she on medication? So again, these questions you need to ask from the examiner, which is basically assumed to be your ST5. So, and then you will say that I will ask the midwife to quickly check this urine and tell us about the protein in the urine, and if she's and ask about the signs and symptoms of preeclampsia as well, headache, and then if that is, then to start her immediately start her on speed preeclampsia protocol accordingly, and start CTG because of the meconium, right? So then you will say, you will ask the midwife actually to inform you quickly with all these findings because she may be a potential preeclampsia or needing any. So for the time being, yes, you all are going to attend your major PPH. That's your first priority. This room 5, it depends if you are told that she actually is dilated. So, that's why it is important. If they tell you, no, the examination has been done, just now, and the os is closed and the contractions have subsided as well, then it's fine. Then she's not your emergency, yeah? But if she has started dilating and contractions have gone more and she's 4 centimeter or 5 centimeter, then we may need to remove this suture basically. And for that reason, then you will need to check, either you will go or you can even ask your outgoing team if she's contracting regular as well now, because again, the time is not given. It says admitted at this time, but it doesn't tell us when the last time examination was done and what was the findings, yeah? So if she's not in active labor at the moment, then it's fine. You can just continue to monitor. And you can leave one of your midwives with her. Just make sure that, steroids and all that has been discussed and given to her. So that's the breech one is obviously if she wants to continue with a vaginal breath, then you will say that you will ask, you would like to know when this examination was done. And then again, you can say she will need to be delivered by ST5 or consultant. But at the moment, obviously, you will leave with the midwife. So in accordingly then now you can ask nobody else is in active labor. Obviously this can be a potential case. You can ask your ST3 to review this woman as well with one of the senior midwives. You can send your ST3 into room 8. Your consultant and yourself will be attending with the anesthetist your PPH, and then once that room 7 arrives, obviously then you guys will decide what needs to be done with that woman.
The twin can be delivered by the midwife, doctor, no problem.
Well, if the twins should be delivered by ST5 or the consultant. However,
but
if
we have only one ST5.
Yeah, so she may not need to be delivering at this stage anyway. She's not fully dilated. It doesn't say. Yeah, that's why we need to know how much dilated she is. So
coming
if
up
you
to
are
second stage.
Sorry?
Coming up to second stage of labor. Written.
Yeah, coming up to, but we don't know what the dilatation exactly is. Yeah, so we need to know that. No, if you are really stuck, then one of the senior midwives can deliver the first twin and then see how, and then you can enter. But obviously, this needs to be. Otherwise, as part protocol, this patient needs to be delivered by ST5 or the consultant. Okay.
Ma'am,
That's what I'm asking. How we will gonna address this? Like we ST5 is busy in the other room, me consultant busy in room 3. Then how we'll gonna answer the question that how we'll gonna arrange the things? That's my query.
Okay, the query is again then from the room 2. Our query is start like you need to check first what the findings are, right? So if she's fully dilated now, this twins pregnancy, then obviously she needs to be delivering. Okay, and the position of the head and all that as well. Then you can ask one of your outgoing team, your ST5, can actually stay and deliver this twin if she's imminent delivery, right? Because the fresh team who has arrived, they need to manage this PPH. So sometime if there are like 2-3 potential type of emergencies where you need to go to theater for more than one patient, or they potentially need, because we don't know how the second twin will behave. So if we say at this stage that you will actually leave one of your midwives to do that, then what if the actually come into cephalic itself and you need to do internal podalic version? Midwife can't do that. They're not supposed to, and they can't do that. Okay, so that's why if she's an imminent delivery, then you will ask one of our, your outgoing ST5 basically to deal with this woman. Okay, so they can stop, they will stop basically when this type of labor room is going on. One room is PPH and the other room is severe preeclampsia, and there is one twin and there is one breech waiting for cesarean section. They will try to sort out, one of these urgent emergencies and 1 or 2 of these before they go. So they're not going to go anyway, but you need to basically say. So for this one, that's why SARTAC is very important to us. What exactly is in examination findings now? And the examiner will give you the findings. Okay, and then you can decide accordingly your stuff. Yeah, so she won't be delivered by the midwife. She needs to be delivered. So if she's still like about just fully dilated at 9 centimeters, something like that, then it's okay, because your consultant is going to arrive as well. Then you can just tell them like when she needs to be transferred her there for the delivery, and then you will come and deliver that baby after this. And if she's fully, you will ask your outgoing ST5 actually to deliver that baby before she goes. Any questions?
Hello, ma'am. Hello.
Yeah. Yes.
Hello, ma'am. What are the
Yes,
vaginal
please.
deliveries to be conducted in theater? Breech, VBAC, twins, all can be conducted in labor room only, ma'am.
So the twins we deliver in theater.
Hello.
VBAC delivers.
Your voice
Hello,
is, ma'am, breaking too
I
much.
can't hear you, ma'am. Can you please repeat?
The
Hello.
breech, if the
Hello. Hello.
Yes, we cannot also listen the doctor.
no, it's a simple state. Extended breech, then you can't the expertise of who deliver them in the room. It depends on that person who really depends on the person who's going to do that vaginal breech birth. And if they feel you can delivering this by cesarean section, but obviously, yeah, you need to deliver in theater. If it's a breech, then you can. These are just complete, but if there are a vaginal route, even in the room, thinking of doing instrumental try or anything, then you will take them theater. Otherwise, they will be delivered in the room as well. Any other question?
Ma'am, sorry, we couldn't hear anything, ma'am. It was all broken, interrupted, ma'am.
Okay, right. So you did ask me, as far as I understand, that the twins breech, who is delivered in the room and who needs to take to theater. The twins, if the second twin is not cephalic, they will be delivered in theater. Extended breech will be delivered in the room, unless there is any other risk factor. VBAC, they are delivered in the room, unless again there is any suspicion at the end that you are feeling of any scar adhesions, or you need to do the instrumental trial, then obviously you will take to theater. Okay, is that your question was?
Yes, ma'am. Thank you, ma'am.
Yeah. Okay.
So, ma'am, according to priority, first priority so how should we start? We should start with the first priority, or we should start by room by room?
Okay, it's up to you. Whatever you have practiced when you're preparing, what you feel comfortable, right? There is no right or wrong way to do it. However, because of the exam pressure and because the scenarios are usually long and everything, and the 2 minutes obviously under the effect of nerves can sometimes be, some people cannot concentrate and focus very much in those 2 minutes. So in that case, when you start doing the room, you start from room 3, and there, unless again you have developed some technique that you're going to actually write your own numbers here to by saying 1, and then when you have discussed, you will tick that room, then it's fine. Then you will know, yes, I have dealt with this room. Otherwise, there is a risk that you will start confusing which room I have discussed and which I haven't. So go back to this room and again this room, and you may miss the time. Okay, so unless you can develop your some technique by saying, when I'm reading outside, I'm actually this one going to mark with my red pen as a room number 1, and this then 2 or 3, whatever. And when you're discussing that room inside with the examiner, when you're done with this room, put a tick as well for yourself, right? But you know, otherwise the most safe way is you can start from room wise, room 1, 2, 3. Now at this stage, if the examiner asks you, is that your priority order as well, then you can say no, I'm just going to and it's absolutely fine to say under the pressure of exam nerves, I'm not going to, you know, I can't just straight away pick up the priority in my room, so I'm going to review my all the rooms first, and then I will decide my priority. Okay, and it's absolutely fine and acceptable. And then this is what kind of you're doing the review. So then you will start your room 1, and obviously when you have discussed that, you will clearly know what is the urgency level, and then you can say at that stage with that information, okay, that's my low priority room, I can wait for this patient, and I will send one of the midwives there. Okay, then you have done the priority, you have done this one, then go to your room 2 and then decide it accordingly as well. So I usually recommend you to go room by room because it saves you from getting confused. It saves your time from jumping one by saying, oh no, yes, I have done this. Have I, you know, done this? And but if you can practice that way and you're very good having control on your nerves, that's fine. You can do that way as well, as long as you don't miss.
Dr. Safia, as regards the breech one, undiagnosed breech one, if she's going for cesarean section and she's in advanced labor, means progressing. So we have now PPH and the breech going for cesarean section. Who will go where? Means me and the consultant will be in PPH. Who will do cesarean section for the breech one?
Right, okay, so the consultant then will need to stick with their PPH, preferably with the other consultant, outgoing consultant, RST5, and then you will go and do the cesarean for breech.
Hello, Dr. Satya.
Yes.
Means you said ke extended breech in multi, no other risk factor we can conduct in the labor room. We can conduct delivery in the labor.
Yes.
And twin, if both twin are cephalic, means then we can also conduct delivery in labor room, correct?
If you ended up that she's fully dilated and there is no chance time left actually to transfer, then you will do, but preferably the twins are, because what happens basically is when the first twin will deliver, second deliver can change the position.
Yeah, okay, so preferably if we have time and all these things, better to whatever
Twins
the
will be delivered in theater.
Okay, if no time or sometimes it happens, then we can take chance in that. Okay.
Yeah.
Okay, thank you.
Last question, doctor. That anesthetic consultant will be busy with the PPS, so the anesthetic SC5 or anesthetic registrar will be busy with the other patient with which has preeclampsia to stabilize her, or where that one will go?
No. Why anesthetist needs to go for preeclampsia?
But we have the two anesthetists. One is the consultant anesthetist and one the anesthetist registrar.
They both will, okay, so remember one thing. The major PPH or major APH, these are the conditions where you need the maximum stop. So don't think like we can unnecessarily take one of the anesthetists or one of the doctors from there and put another one, unless the other one is also dying emergency. right? Now, preeclampsia, the anesthetist needs to we need routine. It will be, yes, if there is no other thing going on, then you will call the anesthetist to deal with the the eclamptic fit or that. But otherwise, unless this woman is in eclamptic fit and she is getting a shisha's collapse, and you need to take help from the anesthetist to secure the airway and stuff, you don't need an anesthetist in for preeclampsia. There's a clinical obstetric emergency. We need to sort it out. Unless, again, as I said, you need anesthetist to secure the airway. So anesthetist is not simply, you're not sending the ST5 anesthetist to say, go and see that patient. No. What is the rest of the protocol? Yes, they know that as well, but you are the prime clinicians to take care of initiating the protocol and everything. So in that particular scenario, if that goes that tight, then your other ST5 and consultant are going to stay on the floor with you as well. Okay. So don't make that mistake by saying you're going to send the anesthetist for the preeclampsia. That just is suicidal attempt, really. So they will stay, both of them will stay with the PPH patient. And then you may need to, as I said, like this undiagnosed breech, if she's like already getting 6-7 centimeters or whatever, and she wanted actually for the cesarean section, even if she's not 6-7 centimeters, she will need to be done on an urgent basis. Immediately after you guys have, that there is sufficient personnel to look after that PPH, your consultant, other consultant, and the anesthetist, then you will need that anesthetist here to give the spinal for you, this lady. But I assume if she's there from 3:30, it's already 5 hours. This woman, when you will ask the examiner, the answer should come by saying that this woman has chosen to go for vaginal birth. Because otherwise it doesn't make sense to keep sitting on this woman till 5, wait for the morning team to come and struggle with her. So that's why it is very important for you to ask when was the last finding, when she was examined, and how this plan was discussed, what mode of delivery she has chosen to go ahead. Right? Okay, so next.
Dr. Sophia.
Yeah.
I had another scenario in day 4 of the exam. One was like high blood pressure, more than 160/100, with imminent eclampsia and protein 3+ and headache. The other one, it was she is placenta previa, retained placenta, but she's a known case of von Willebrand disease, and she had history of previous BPH, severe BPH in the last delivery. And the third one, it was pathological CTG, fully dilated for I think more than 2 hours. So which one we will go first for these 3?
So one is severe preeclampsia, and second is your placenta previa. Is she bleeding? Is she in labor?
No,
what is happening with
retain the placenta for more than
placenta.
I think 1 hour. Yeah, but she is von Willebrand, and she had history of BPH before.
All right, okay. So then you need to ask, obviously, when she has delivered, and then you need to check about
1 hour ago.
Okay. So severe preeclampsia, if she's then that again depend as well, like has the protocol already. So when you see those, that doesn't mean the protocol hasn't been started already. So you need to ask first again then that is she stabilized now, has the preeclampsia protocol started already, and has she's been on IV and this one. And if not, then what you need to do is you need to go for retained placenta immediately. You need to call your consultant here as well, again, because you don't know your retained placenta start going into PPH. And even for preeclampsia patient point of view, you need to call your consultant. But otherwise, and then the other room who is fully dilated, if there is, then depends what is the position of the head. If the head is already like below spines and the position is occipito anterior, then you're even ST2. If it's ST3, then the ST3 certainly can't do that outlet force and delivery. So you will send your ST3 to do the delivery. And if it's ST2, your ST2 should be competent as well. But you will say, I will check if ST2 is, competent to do the outlet delivery. Then you will send your ST2 to do that delivery, to deliver that baby. Okay.
In
you
this,
will
we
go for
will
88
ask
plus.
for the
So
going
first I
gene,
will go to the
the
PPH,
going
the
gene
risk
of
for PPH.
Yes, PPH and APHs always take the priority. So imminent potential PPH or active PPH or APH same way, because they can be, you know, really disastrous. So they will always take the priority. Okay, but if the case was like this is retained placenta just half an hour ago, she's not bleeding, no other risk factor, then you could actually sort out the other two patients first and then, you know, take her, meanwhile, take quickly after her to get ready for theater. But because this lady previously has the PPH history and she has obviously then some problem as well with her clotting and stuff, so you will basically, she will get the priority here.
Doctor, can I send this scenario for you, because it's has too much tricky. Like I see now the blood pressure was 180 over 100, and it is IOFD baby, intrauterine fetal death, and there is another one undiagnosed breech, primary 9 cm.
Okay. So you need to send us scenario then, and we can discuss it either tomorrow or with our delivery module. And that's why, girls, I encourage you all actually to send the relevant scenarios before the session, so we can put on that, and that can save our time as well. So, okay, send that scenario to me on WhatsApp, and I will put for tomorrow's slides.
Okay, doctor.
Okay.
Dr. Sophia, I
Right.
have a question.
Yes, please.
I have one question. If a patient is fully dilated and pathological CTG means we will see if it is instrumental delivery possible, then we will take it for instrumental without taking the fetal blood sampling. Fully dilated.
When the patient is fully dilated, then you don't do the fetal blood sampling. Okay, or
Okay.
that depends on the, okay, so that will also depend on the CTG, you know, if it's a pathological CTG, then you need to deliver this baby, right? And then whether you're going to do the instrumental trial in theater or in the room, that will depend on the position and station of the head.
Yeah, that okay, means in the room or labor room, but we will not do the fetal blood sampling
Full
at fully.
dilatation, yes, full dilatation, you don't need to waste your time on fetal blood sampling, you need to deliver that baby.
Okay. And if it's suspicious CTG and patient is fully dilated, then?
If it's a suspicious CTG and the patient has just become fully dilated, maybe primary gravida, and just
Then
like
we can
half
do.
an hour, then you can do fetal blood sampling. Yes.
Okay. Means in pathological CTG fully dilated, no role to do the waste time in doing fetal blood sampling.
Yeah, unless he has just done fully and the station is bit, you know, high as well, then you can just take the fetal blood sampling.
Okay.
Right.
Thank you, Dr. Sir.
Welcome. Okay, so the next one. Okay, so right. Okay, Dipti.
Yes,
Okay,
ma'am.
we have. Okay, so let me just check with Surujna first. So, hello, Surujna, are you there?
Hello, ma'am. Yeah, I'm here.
Okay, Srijana, would you like to do the next station?
I think I'm not yet ready, ma'am. Maybe from tomorrow I can.
Okay, no worries,
Okay.
no worries. Right, Dipti, so I'm coming back to you then. So this next station is for you. This is for you, Dipti.
Okay.
Okay, that's your first 2 minutes.
Hello, I'm Dr. Deepthi, one of the doctors in the clinic today. Can I confirm your name and age, please?
Yes, doctor. My name is Joe Ferguson. I'm 37 years old.
How would you like me to call you?
You can call me Joe.
Joe, I understand that you have come here to discuss about your birth plan, and this is your second delivery. Sorry, this is your third delivery.
This is
Is
third.
that
That's doctor. That's right, doctor. Yeah.
okay? So before discussing about your birth plan, is it okay if I ask you a few questions about you, and then we can together discuss the management options? Will that be okay?
Yes, that's fine, doctor. Yeah.
Okay, Joe, can you tell me what are your concerns today?
Well, I'm here because I wanted to discuss the mode of delivery. I mean, I want to have a cesarean section done for this baby. First I had a cesarean section. That was my baby was breech. And second time I was offered to try vaginal birth, which I did. But I really have an awful experience with that one. And to be honest, I just didn't like it, and I just don't want to go, go to that situation again. I want to have a, planned cesarean section and just have a nice clean birth as I did first time.
Okay, I can see you are a bit stressed about your second delivery. Can you tell me what happened and why you are thinking about cesarean section again this time?
So my labor first was very prolonged. It was a really long labor. And then the plan was I would take epidural, but that couldn't happen. I could have epidural really late, so I wasn't really prepared for labor pains and stuff, so I found it really difficult. And then my placenta didn't come out itself, and I ended up going to theatre and have anesthesia and then taken out. So I just this time I don't want to go through that uncertainty and those pains and everything like that at all. I would rather like to have a planned nice delivery.
I'm sorry that you had to go through that difficult situation. This time I will help you as much as possible to reach your expectations. Coming to your current pregnancy, how is pregnancy so far?
Pregnancy has been fine. It's pretty straightforward. I don't have any problems at all. All the tests, my 20-week scan, everything's been normal. Yeah.
Okay. What about your baby movements? You are perceiving good?
Yeah, baby movements are excellent. Yeah.
Okay. And regarding your first delivery, can I know why the operation has been done for that?
So the baby was bottom down. It was breech baby.
Okay. And any complications during the operation or afterwards?
No, it was absolutely fantastic experience.
Good, good. Okay. So have you had any medical problems that you're following up with GP?
No.
Okay. Any other surgeries other than this cesarean operation?
No, doctor. That's no.
Okay. And are you taking any medication?
No.
Okay. Any allergies? Any drugs to or substances?
No.
Okay. Okay. And Joe, do you smoke?
No, doctor. I started smoking in pregnancy.
Okay. What about alcohol or any recreational drugs?
No, nothing like that either.
Oh. Joe, do you know your height weight ratio?
Yes, it's been 23.
Good, good. Okay. And whom do you live with?
I live with my husband and my 2 children.
And you feel there is enough support at home and everything is okay?
Yeah, it's been fine.
And is there any problem of blood clots in legs or lungs in yourself or in your family?
No, doctor.
Okay. And during the past few weeks, do you feel a bit low mood or any depressed kind of thing like that?
No, doctor.
Okay. So, Joe, what I'm going to do now is I need to examine you in the presence of the chaperone. My nurse will take the pulse rate and blood pressure of yours, and I will examine your tummy. Okay, and so coming to your options of your delivery. So you are expressing your wish of having another cesarean section this time now. We respect the patient wishes, but what I am going to do is I'll give you the options, and we will discuss the risks and benefits of each option, and you can come a decision by taking that information. Will that be okay, Joe?
Yeah, that's fine. Yeah.
So the option of having this cesarean section again, this will be your second cesarean section. So this time the cesarean will be done after 39 weeks, so that your baby will get the full maturity. And this time, as the number of cesarean sections increase, there will be more risk because there will be a scar tissue formation inside. So there will be more chance of bleeding and having this infection. Sometimes there can be having injury to other structures, the surrounding structures. And as you know,
Yeah.
for surgery, there will be a risk of prolonged hospital stay. And so in future pregnancies also, there is more chance for you to have another cesarean section. And sometimes the afterbirth, sometimes it attaches abnormally, and there will be risk of bleeding in further pregnancies also, and rarely it may lead to removal of womb operation also. So do you want me to discuss about the vaginal delivery option this time? I'll just give you the information so that you can make an informed decision about that. So,
Well, yeah. I mean, I think I have decided to go for cesarean section.
okay. I'll discuss this with my consultant and arrange another appointment with my consultant. So if you could think about having a vaginal delivery this time, as you have told previously that you are having this delay in getting an epidural, so I can make an arrangement with an anesthetist. He will examine you and decide when is necessary for you to have this epidural. So as and when you come into labor room with strong contractions and you are in active labor, I will make sure that you receive the epidural as early as possible. And regarding the long labor, we will because you are after cesarean this time, and you had a vaginal delivery previously, there will be a 90% success rate to achieve a vaginal delivery again. And this time we will be monitoring you continuously, and any help you need during the delivery of the baby, we can assist you. And the benefit is you can have an early recovery and a shorter hospital stay, and bleeding can also be less. Sometimes regarding this placenta afterbirth being retained inside for a long time after the delivery, it can happen even in cesarean section also. So for that, even it can happen in vaginal delivery. For that, before only we will give you medicines to assist in early delivery of the afterbirth. Okay.
Okay. Right.
So would you like to consider the options? I will give you the written information about what all we have discussed. You can come with your partner in the next appointment, and we can together discuss along with my consultant. How would you like that?
Vaginal birth. So can you really then guarantee me that I will have the epidural right in early labor?
Yes.
I don't want to risk. I don't like the risk.
Yes, what we do is when you come to the labor room, we will assess you, and we will find which stage of labor you are, and when the contractions have well established, the anesthesia people will examine you, and I'll make sure that you get your epidural as early as possible.
Okay.
And do you have any?
I'll have a. Well, I will need little time to think about then to speak my partner.
Yeah, sure.
To make a plan then.
So if at all you consider for having another operation, it will be at after 39 weeks, but some of the women may go into labor before 39 weeks only. So you need to take a decision about that before 39 weeks if you are going into labor, whether you wish to have a surgery or vaginal delivery, you have to make a decision. So I will note down your decision in your notes.
Yeah.
Okay.
Okay, doctor. Right.
Okay,
Your time is over.
Thank you.
Right. Okay. Good. Thank you, Dipti. Yes, you did include things, everything almost you discussed the way, but you are a bit like backward forward. So you did tell me like you didn't tell me any advantages of having cesarean section. All was talking about what are the risks of cesarean section. And then you offer me to say, would you like to know about the vaginal birth? And I said, I don't want to because I have made a decision already. And then you still go on with the vaginal birth. And then after that, I want to think about it. I say, okay, I will think about. And then you talk about the cesarean again to say, book it 39 weeks. So, it's fine. You still will say all these things. Well, what happening is, it looks like you don't know. You're just going backward, forward, backward, forward. So talk about the vaginal birth, finish every benefits, disadvantages, whatever with that first, or with the cesarean, whatever you want to choose first is fine. And complete fully with that, and then go to the other one. If you will ask the patient who has already come with the mind she want to go for a cesarean section, if you will ask her, would you like to know for vaginal birth as well? She's certainly going to say no, because she has made the decision already. And then it appears a bit not quite right and a bit rude that we still go on over the vaginal birth, because if we have to talk about that, why to us? So the way, the counseling of these such sessions you do is in the ways, keep your language and options open, and give the information in a way that, she can actually compare both. So when you are saying, and she's repeatedly saying, I had a very nice experience, neat and clean delivery, knew everything. So this time when you're talking about cesarean, which you did, that there may be risk of injury and all that, you need to compare with the first one as well. If you simply tell me, I have listened this whole story with my first cesarean as well. I was told, there can be the risk of placenta attack, there can be bleeding, there can be, but nothing happened. Yeah. So I'm quite reassured by thinking, no, that's going to be straightforward. So you need to basically tell me your risk of having these are higher than your first one. Okay, so this risk of placenta getting it there become higher as well this time. And sometime, if that happen, it can lead to life-threatening bleeding as well. So you need to give me really a picture where I can actually compare between both. Okay. So when you start, you can start by asking first, when she says I had a bad experience, you need to just a little bit acknowledge and kind of apologize by saying, I'm sorry that you had to go through that unpleasant experience. But sometimes there may be, some urgent cases and emergencies which the anesthetist needs to deal with. So, and then in that case, obviously these epidurals can be delayed. So I'm sorry that you have to, take the labor pains which you were not mentally prepared for. No, she says, can you guarantee me I will be able to have the epidural? We cannot guarantee, right? So it's not like, it's not my job to actually really push and do everything or anything to make sure she does go for a vaginal birth. Yes, we want to encourage her to go for a vaginal birth, but at the same time, you need to make realistic promises as well, because we really can't guarantee. So I will say, well, we're going to put a written plan this time. So we will put you for priority for epidural, and we will like to, we will try our maximum best that as soon as you come and we do your assessment and you're in active labor, we get your epidural in place quite early in labor. However, obviously we cannot promise 100%. Because it's so unpredictable. If there is some life-threatening emergency on the other side which anesthetist needs to deal, then obviously you will need to wait. So this is how you will answer that question. So in summary, you basically will start with, but say, I'm sorry that you had to go through all that. You did establish focused history, which was fine. Briefly ask about the first section, were there any problems during this operation or after recovery? Were there any problems of your second, other than obviously placenta being retained? You did exclude any postnatal depression, which was very good. And then you just establish this pregnancy has been low risk otherwise. Then you need to say, okay, so let me just give you some information about both the procedures, the vaginal birth and the other one as well, so that you can compare and balance. So I will actually start with cesarean section first, because I will start with the vaginal birth first. She's not prepared basically to listen about the vaginal birth benefits. She just is thinking, she will be casual to think about, well, I want cesarean section, doesn't matter what you're telling me. So I basically will start with the cesarean section, because once I will tell the risk of repeat cesarean, she will be probably more open to listen about vaginal options. So I will say, okay, so that's all right. So you had the cesarean section before for the first baby, so you have some idea what to expect. However, this cesarean section second time will have slightly higher risk of complications as compared to the first one, because when you have one operation, it heals with some scarring and adhesions inside your tummy. Your bladder bowel are just very next to your womb, and they can actually get stuck with the womb. So on the repeat cesarean section, when we do, before we can open the womb, obviously then we need to separate these bowels or bladder from your womb, which obviously will carry a slightly higher risk of injury to your bladder and bladder as compared to your first cesarean. And it can obviously lead to sometimes quite heavy bleeding as well. And then second, once you have the cesarean section done, then the risk is that the next time, there is a highly likely that you will need to have a cesarean section done, because the area of the womb where we open repeatedly, that will get scarred again, and that area become thinner. So there will be a more risk of rupture of your uterus during pregnancy, which can also lead again to life-threatening bleeding for you and the baby. And the risk of then your placenta getting attached and stuck into the scar in your next pregnancy will be quite high as well. So these are a few serious complications you need to just keep in mind. The things may go straightforward as well, but obviously the risk is low, but if they happen, these risks are severe. So that's why I would like you to just keep those in mind before you take a decision. The serious section, if there is no complications, then it is better option for the baby. However, we have seen that these babies, sometimes when they are delivered, they can sometimes have some breathing problems immediately after the birth. But that's something is the pediatrician will attend the baby and see the baby anyway. So regarding vaginal birth, I know obviously there can be some uncertainty about that, that you plan for the vaginal birth. So there is a possibility, there may not be a progress, or the baby may get distressed, or maybe heartbeat goes upset, and then we may end up of doing emergency cesarean section. However, you have one vaginal birth already, so your chances of having second vaginal birth are quite high this time. If the things go straightforward with the vaginal birth, obviously, it's very simple and straightforward. It's less invasive. It won't have any risk of, injuries to your bladder and bowel, as I said, from adhesions and anything. And your recovery is very quick. You will be able to be up and about within a few hours. However, with the cesarean section, obviously, it will need you at least more than 24 hours before you can, be quite good up and about. Which can increase your risk of blood clots in legs and lungs after cesarean as well. So regarding your placenta, once you have that problem, your risk of getting retained placenta is slightly higher in the second pregnancy as well, in the second delivery. However, we are aware of that, so we will be quite vigilant basically to give you some injection at the time of birth of the baby to ensure that the placenta gets separated timely and get delivered as well. So regarding epidural, obviously you have said to her, I will make a written plan in your notes, and we will, make sure when you come, we get it sorted out earlier on. However, if she says yes, you can plan or you can promise, however, it cannot be promised, because if there is some life-threatening emergency, that gets the priority, and then the cities may get busy over there. So after now having a good insight into the benefits, the advantages and disadvantages of both the procedures, you can now have a little think about it and then make a decision. And then you can ask, like, at the same time as well, so what do you feel then? What would you like to do? Would you like to consider to go for vaginal birth, trial of vaginal birth, or you would rather still you think you would like to go for cesarean section? If she tells you straight away, then it's fine. If not, then obviously yes, you can say okay. So yes, that's fine, no problem. You can take some time to think about, discuss with your partner as well. However, it will be a good idea if you can reach some decision in next, a few days, because if you want to go book for cesarean section, then I will need to book you on the list by your 39 weeks, so that you are booked in that list, and we have done the preparation for you. I will give you the written information of both modes of deliveries as well, to help you to decide what mode you would like to choose for you. Do you have any questions? Okay. You don't need to particularly bring or book this patient to be seen by your consultant just to discuss the mode of delivery. If you're ST5, you're fine. But yes, if she chooses to go for cesarean section, then you will say, okay, I will let my consultant know as well that you want to go for elective cesarean section, and then we will put you on the list as well. And that's just because, obviously, if you're putting on the list, consultant needs to know. But just for this counseling, you don't need to involve your consultant. Put another appointment for the consultant. Right. Any quick questions before I take 10 minutes break? Okay. So we're going to take 10 minutes break and then come back and do the remaining scenarios.
This conference will now be recorded.
Right. Okay. So let's go to the remaining stations now. Right. So Mala, next one will be for you.
Okay, Dr. Safiya.
Okay, this is for you. Okay, that's your first 2 minutes.
Actually, Dr. Safi, I don't know how to do this, but I will try.
Okay, that's fine.
Okay. So first of all, when I will see this patient in the room, and she is collapsed, I will call for the help immediately. And meanwhile, I will check her for breathing and pulse. And meanwhile, I will take history from the midwife, why she was admitted and what was her
Yes, yeah.
yeah, I mean, as per the what was her vitals before and what happened before, and meanwhile call for the help. And if there is she is not responding on my when I will call her, if she will not respond, then and check for the breathing and then start CPR. And
Okay, so tell the details of the CPR, what that will involve.
this first is breathing with
Right. Do you want to continue? You would like somebody else to take over?
somebody else will take over.
Right, Dr. Radat? Hello, Dr. Radat?
Hello.
Yes, Dr. Radat, would you like to do this scenario?
Yeah.
Yeah, okay.
Hello.
Hello.
Yes. This is 28 years old lady in her 6 weeks pregnancy. On my arrival, I found her is unresponsive. Immediately, I will activate the emergency buzzer, call for help, and I went to the patient, ask the patient, hey, are you, sir, are you okay? Patient unresponsive. Immediately, I will check the airway. Any obstruction, I will remove any secretion suctions, assess her breathing, and start immediately CPR. Effective CPR. Check the scenes effect. Yes. CPR 32.2. We 32.2. Yeah, effective. That 5 centimeter in depth. 100 to 120 per minute. Yeah. Then when the team was arrived, we'll distribute to the teams. One will take care for the airway. We'll insert the IV line to wide bore cannula in each line. We'll take blood for lab test. Electrolyte, kidney function and liver function, coagulation profiles. Putting at this time thinking about what is the cause of heart collapse in this patient. One will be the team leader, coordinate the management of the patient. IV line, start the IV fluids. Yeah.
Okay.
Yeah, when the team arrived and the defibrillator is available, we will attach the defibrillator. On the right side will be on the horizontal from the second intercostal space, and in the left side in the this in horizontal and that one in the oblique, in the at the apex, just below the nipple. We'll analyze if the patient needs shock at any time. We will shout clearly, be away from the patient. The device automatically will read the shock if the shock aporism is there, which was ventricular tachycardia or ventricular fibrillation. If shock advised, all will be clear from the patient, even oxygen, and the shock will be released. The shock needed according to the etiology, ranging from 160 to 320 joule. Then we will intubate the patient as soon every 2 minutes. We will check the pulse if there is a risk or not. If there is no risk, we will minimize interruption between compression. Then during the course of the management, we will think about what's the cause of this. We will discuss between the team. The team by now there should be anesthetist came and consultant obstetrician came and intensive care specialist came. The patient should be intubated as soon as possible. Once the patient is intubated and ventilated, the chest compression should be continuous at a rate of 100 per minute.
Okay, so it's 4 minutes CPR, but the patient still hasn't responded.
Yes, patient not responsive within 4 minutes. Here we'll undertake immediately post pre-mortem Caesarean section. This Caesarean section is best interest of the mother, not the baby. In spite that they are showing that there is a good outcome even for the baby. The baby is term and alive. All what we need for this Caesarean section, we need a scalp and 2 clamps, which should be available in the trolley. Then after delivery of the baby, we will continue CPR, and if the rose attended, we will take the patient to the theater to continue management under aseptic condition, closing the wound and sutures, and cover the patient with broad-spectrum antibiotic. Then, according to the underlying etiology of heart collapse and unresponsiveness, the management will be to this patient. Either cardiac cause, will put in my mind is the underlying cause. The most common cause is the 4 T's and 4 H's. Toxin, tambonate, cardiac, tension, pneumothorax, thrombosis, either pulmonary embolism or myocardial infarction. Hyponatremia, hypokalemia, hypoglycemia. Whatever the cause, we will involve the specialty. If the myocardial infarction or cardiac origin, cardiogenic shock, will involve the cardiologist as soon as possible. And the patient would be managed by the specialty and multidisciplinary team and intensive care and the intensive care unit. Then, if the outcome is good, this if the mother is alive. If the mother is was dead, died, then we'll involve the coroner. We will notify the MCAE.
When will you decide to stop CPR if the mother is not responding?
Yeah, CPR, there is no clear cut to stop CPR. This should be a discussion between the consultant obstetrician, consultant anesthetist, and the resuscitation team.
Okay. Okay. So, right, okay. So, let's say this patient hasn't responded and the CPR decision is taken to stop. What will you do from there?
Yeah, if the decision taken to stop the CPR, then we will confirm the death of the woman. We will check the pupil for reactivity. If are reactive, this means that this is confirmed. We will notify the coroner. We will keep everything in place. If the patient intubated, the tube in place and everything in place for the coroner to assess if in case of postmortem examination is needed. Then we'll notify to the CMA the patient. Then we need to do an incident report.
Yeah.
For this patient.
Okay. Right.
Yeah.
Okay. Good. Just few things we need to get it corrected here. So regarding the strength of the shock, you said it will be from 100 to 320 according to the cause. Do you want to explain that? What, like, how will it change and what conditions it will change? Hello, Dr. Radha.
Hello.
Yes. So regarding the strength of the shock, you said it can range from 100 to 320 according to the cause. So how will that range and how you decide? So like what level is it?
This is depending on the underlying reason on the monitor and the response of the patient. Ventricular tachycardia, ventricular fibrillation will start with 200 joules. And usually atrial fibrillation and atrial fibrillation require less, even less than 100.
Right.
But the most common cause is atrial fibrillation, and if the rhythm is asystole or pulseless electrical activity, this is a shock not advised here. We will continue giving epinephrine 1 milligram every 3 to 5 minutes.
Okay.
Yeah, and even with the shocks also, we'll give every 3 to 5 minutes epinephrine. After the first shock and first and second epinephrine, we will start amiodarone also for the woman for ventricular tachycardia and ventricular fibrillation. Okay. Amiodarone 150 bolus, then can be repeated.
Right. Okay.
Yeah.
Okay.
Once is once a ROSC is attained, we will deal with the hypothermia, the blood pressure, IV fluid warm, the normal saline will be started and will be managed according to the blood pressure, and then according to the underlying cause and specialty, and 12 lead ECG should be taken as soon as possible.
Okay. Right, okay, so time is over now already. So let me just correct this shock strength story first. There is no variable range of the shock. When the shock is advisable, it will be the same strength, and it's always 360 joules. The other condition when you say there is ventricular tachycardia or atrial fibrillation, either you give shock, so either that is a shockable rhythm or it's not shockable rhythm. We don't change the strength of the shock, right? You don't give the shock at atrial fibrillations. The shockable rhythms are only ventricular fibrillation and ventricular tachycardia. So VT and VF are the shockable rhythms. Atrial fibrillation is not, that's not shockable rhythm anyway. So you don't give human reduced shock. So that's one thing you need to be careful about. Regarding second, you forgot basically, I know in the beginning you did call for help, but then you forgot basically to call your cardiac arrest team. So unless you call, they're not going to arrive that ever. So that's very important. So there is a fixed ways of saying that as well. This is a very kind of national way of describing and saying this as well. And this is what we practice in our drills as well. So you must say exactly the same way, which I will say in a minute. The defibrillators, they are automated defibrillators, and they are present almost on every unit. So in labor ward, the defibrillator actually is present on the midwifery station, and you will get the defibrillator before even your cardiac arrest team arrives, because they will still be coming from some part of the hospital, so it can take them, you know, a couple of minutes or even more than that to arrive. But we know as per evidence, earlier you basically give the shock, the chances of recovery are better. So we don't delay that shock. So you will have for that reason, automated defibrillators are basically present. Even in the corridors of the hospital and in OPDs, everywhere they are present. So they are within the easy reach and access. Okay, so for this patient, the way you will start, again, as I said, like it's a standard, so you will all need to listen it a few times and just to memorize basically exactly like this. So yes, you will say, as soon as I will notice this patient has collapsed, so she's on the delivery suite already and inside the room, I will immediately pull the emergency buzzer so that I can have some other staff available to come down to help me. Then I will see if it is safe to approach to the patient. Then I will approach the patient and shake her from her shoulders, and I will say, Sarah, are you okay? Sarah, are you okay? If the patient does not respond, then I will immediately check for her breathing by look, listen, and feel. And for that one, I will immediately put her into head tilt and chin lift position, which will straighten the airway passage, and I will try to listen for the breathing and feel for the carotid pulse at the same time. If there is no breathing, I will immediately check for any obstruction in the airway, and if there is any visible obstruction which I can remove safely, I will remove that and then check for the breathing again. If there is no visible obstruction and the patient is still not breathing, then I will immediately call for help for the cardiac arrest team. So I will ask my colleague to call the cardiac arrest team and tell them a pregnant woman has collapsed in room 4 of the labor ward. I will also advise them to open the doors of the delivery suite so the cardiac arrest team can access the patient quickly and immediately. Then you will start immediately the CPR. So because you are in the room, you will ask one of your midwives to put the oxygen mask by putting the patient's head tilt and chin lift position, and then you will be starting chest compressions. Chest compressions will be done at the rate of 100 per minute, and the depth of the chest compressions, you will ensure that the chest requires 1/3 of its full thickness. You will immediately like to tilt the patient as well to remove the weight of the gravid uterus from the major blood vessels, because that is what's going to seriously compromise the effectiveness of the CPR. Preferably, a spinal board will be used and the patient will be tilted at the degree of 15 to 30. Meanwhile, when you're waiting for the bird, then if the patient can be tilted, you know, the couple of staff members basically tilt the patient slightly or manually remove the tilt the gravid uterus to release the pressure from the blood vessels. Okay, so the chest compressions will continue. You will ask one of the staff members to immediately bring the defibrillator from the delivery suite. As soon as the defibrillator arrives, then you will ask one of your colleagues, or you will give the over of chest compressions to other colleague, and you will immediately open the defibrillator. This defibrillator are automated and they come with the full instructions chart inside. Okay, so you will open the defibrillator and there will be 2 chest pads inside the pad. You will put one pad in a vertical position on the right side. It will be demonstrated on the picture anyway, but that's like the second intercostal space, you know, vertically, and the other will go at the apex of the heart, which in pregnant women will be in mid axillary line, just below about the nipple of the breast. So once the pads are attached, then you will switch on the defibrillator, and the defibrillator will then start assessing the rhythm of the heart. Okay, so if the cardiac rhythm is in ventricular tachycardia or ventricular fibrillation, which are shockable rhythms, then actually the defibrillator automatically advise you to deliver the shock. So before you deliver the shock, you will make sure that everybody's away from the patient and oxygen mask has been taken away from the patient as well to prevent any risk of electrocution and the fire, and then you will deliver the shock. After the shock, the chest compressions will restart immediately, and the defibrillator will start assessing the rhythm. Meanwhile, you'll ask one of your colleagues to pass 2 whiteboard cannulas, take the bloods, and you can tell the details of the bloods, like full blood count and group and save and coagulation profile, LFTs, RFTs, and UNAs. You will be thinking from and try to get the information about the possible causes, reversible causes of the cardiac arrest, which can be your 4H and 4Ts, and 4H are hypertension, hypothermia, hyperglycemia, and hyperkalemia. And your T's are thromboembolism, toxins, tension pneumothorax, and cardiac tamponade. And then obviously, you will just ask the midwife. Now, at this stage, you will ask parallel to give you information about whether any risk factor with this woman as a risk factor of preeclampsia, or what other risk factors were there in this pregnancy or in the medical history which could lead to the cardiac arrest. So that will be working. And then you need to continue if the examiner doesn't interrupt you. Then you will say, so, this cardiac resuscitation will continue for 4 minutes. If the patient hasn't responded within the 4 minutes of resuscitation, then you will take the decision to deliver this baby by perimortem cesarean section. So the cardiac arrest team, when we said in the beginning, you will call for the cardiac arrest team, just for your knowledge basically, and you can say that as well. Now the obstetric cardiac arrest team will actually, in addition to the routine cardiac arrest team, that will involve the obstetric anesthetist and the obstetric consultant as well. Okay, so you may like to say that when you, in the beginning you said, I will call the cardiac arrest team. Okay, coming back to the 4 minutes then. Okay, so then you will say, and if the patient hasn't responded yet, then you will immediately do the perimortem cesarean, which only requires obviously a scalpel, and that can be carried out where the resuscitation is going on, and you will just immediately deliver the baby. That should complete within 1 minute. And delivering the baby will significantly improve the CPR effectiveness, and then the cardiac CPR will continue. If the patient then responds to CPR and recovers, then she will be transferred to the theater, where you will obviously secure the hemostasis, suture the uterus, and close the abdomen, and deal with any other bleeding or any complications. And then this patient will be transferred to either intensive care unit or cardiac care, chronology care unit, depending upon the cause which might have been identified by that, for obviously the ongoing further monitoring and further investigations and the management. Okay, so you will be involving, obviously, you need to say you will be involving the cardiologist in this and the consultant of intensive care unit as well, in addition to your own consultant and the anesthetist and the cardiac arrest team. So once the patient is been stabilized, and then you can, if the examiner take the discussion that side, what complications can happen. Obviously, you should be aware according to the causes, if it will hemorrhage or bleeding, obviously DIC, acute kidney failure, all those things you need to monitor. Otherwise, you can continue by saying, so when the patient is stabilized and conscious and able to understand things, you will then debrief the patient, because it can be quite traumatic and stressful experience with the patient, which can actually lead to even postnatal depression or any long-term psychological disturbances. So you will make sure that you arrange appropriate counseling for the patient as well, explain her about the procedure, what has been done and how that has been corrected. Make sure you will arrange the appropriate follow-ups and the regular monitoring before patient is discharged. And the time of discharge, again, you will speak to the patient to debrief again, make sure if she has any questions to answer them. This will be reported as a risk incidence, and you will then at the end you will do a comprehensive detailed documentation of all the incidents. Okay, if the patient does not respond to the CPR, Then, a collective decision will be taken by, again, your static consultant, cardiac arrest team, and the anesthetist to decide when the CPR should be stopped and the patient needs to be declared dead. You will make sure the family is being debriefed and explained everything which is going on as along the whole process. And then if the patient has declared dead, then you need to obviously make arrangements for the support and the counseling of the family. Preferably then you will leave the patient in that position at that place with all the intubations or any other lines in place. For the postmortem, you will immediately contact the coroner to report the maternal death. You will also report the maternal death to your confidential inquiry maternal deaths. And then again, the same thing, there will be incidents reporting will be done, comprehensive documentation. Then you will need a debrief for the team and also ongoing assessment for any support and counseling for the staff in case of patient death. That will be arranged. So this is how you will conclude this scenario. This is how exactly you need to speak. So you all need to really memorize this. Any quick questions before I go to the next scenario? Okay. Right, okay, so Dr. Radat has done as well now. Is Dr. Rehab, has she joined us or not yet?
Hello, ma'am.
Yes.
Is there any time limit within which we should inform this maternal death, ma'am?
That is informed immediately, preferably within 24 hours.
Okay, ma'am.
Okay, Dr. Rehab is not with us. So I can take this to Dr. Berji. The next one is for you.
Sorry, doctor, to interrupt you. Doctor, you said now that question that when to stop the CPR. So you said it, but I was not able to grab the answer. And what should be the situation in which we should stop? Like after 30 minutes or after what?
Okay, no, there is no time limit. There is no time limit. Sometimes it can continue for 6 hours, 8 hours. So if it says when the patient will be declared dead, if this asks when it will be declared dead, then obviously you need to say it will be on the decision of the combined team, anesthetist, your obstetric consultant, and the cardiac arrest team. Now, when they say when the CPR will be stopped, actually there can be 3 scenarios. If the patient has recovered, yeah. So that's the first possible scenario. The patient has recovered, or if the patient is not responding for some time, then obviously after a complete, the discussion between the consultant obstetrician, anesthetist, and the cardiac arrest team, they will decide when to stop the CPR and declare this patient dead.
Okay. Thank you, doctor.
Okay. So, Dr. Birji? Birji, are you with us? Right, so I have no response from Birji. Faiza? Hello, Faiza? Sundars? Hello, Sundars? The Birji in hospital, she can't do it, but are you there, Sundars? You are logged in. Faiza or Sundars?
Hello, ma'am. Yes, ma'am, I'm here.
Okay, so this next one is for you.
Okay, ma'am.
And who is this? Is it Faiza or Sundars?
Yes, ma'am, Pfizer here.
Okay, Faiza, this one is for you now.
Okay.
No, not this one. I don't know why that is here. Any? Give me 1 sec. Okay, that's for you. Oh, sorry. This is for you, Tyler. Yes.
Yes, ma'am. Hello.
Hello, doctor.
Hello, I'm Dr. Faiza, one of the senior doctor in the clinic today. May I confirm your name and age, please?
Yes, doctor. My name is Laura Thomas, and I'm 30 years old.
Nice to meet you, Laura. As I understand it, you had a difficult delivery 2 days back, and your baby was shifted to a special baby unit for observation. And anything else you want to share today?
Yes,
Any
doctor.
concerns, Laura?
Yeah, I'm really, worried about my baby, and I'm feeling really, low and guilty that my baby had to suffer because of me,
Mm-hmm.
I mean,
Okay.
I would have pushed properly, and the baby didn't need these instruments. Baby would have been fine. So,
Laura, have you met your baby?
Yes, yeah, my baby is with me. He's sleeping at the moment.
Is it a boy or a girl?
It's boy, and he's called Peter.
Very nice name, Laura. So you can see that baby is okay now, and the baby was kept under observation for some time in the special neonatal unit. But now, according to the doctors, the baby is doing fine, and he has been handed over to you. So I know you must be happy for this. Why do you think that you are responsible for this, Laura?
Because maybe I didn't push well, and I could have done something to avoid these forceps. Yeah, and I'm worried, that the baby has this problem after the birth. Can baby have this problem again? Yeah.
Yes, Laura. Laura, let me tell you that it was nothing that was nobody is going to blame you for this, because you are in any case you are not responsible for this. What happened? Because I understand that it was your first delivery, Laura, and sometimes it is really hard to push for the women, and you know, the first delivery and that also the vaginal delivery, it is a difficult one. So sometimes some complications may occur. Sometimes it is really difficult and hard for a baby to come out from the down below. So sometimes some complications may occur. So Laura, let me tell you that you cannot blame yourself for anything that happened to the baby, because we all the teams of doctors are always there to look after you. And if there is any life-threatening situation for you or your baby, we are there to handle you. So please don't think like that you are responsible for your baby condition. And the very good thing about about your baby is that he has been handed over to you, and according to the peds doctor, the baby is doing fine. So Laura, any other concern you want to share?
Yeah, I haven't been able to sleep last night. I've been really worrying about the baby. I'm worrying about if he's gonna have some problems again. And so I just can't, keep I can't bring my mind at rest. I haven't been able to sleep. So I think if you can write down some sleeping pills for me, I may feel better.
All right, Laura. I will definitely write for you. Is it okay if I ask you a few other questions regarding your health? Is it okay? How do you feel about it?
Yes, doctor.
All right, thank you, Laura. So I understand that you had a difficult delivery and some instruments were applied. So how was your pregnancy? How was your pregnancy? Was everything okay during the 9 months?
Yeah, otherwise it was fine. Everything was okay. I was told baby's doing fine. I'm doing okay. Yeah.
And could you tell me more about your partner? Is he around now?
No, doctor. I have immigrated to this country in the beginning of my pregnancy. So my partner is still back home. So I'm really alone here. I mean, I'm living in asylum accommodation. Yeah.
I understand, Laura. This is a very difficult part of your life that you have moved here alone. I understand. I can see that you are quite worried. So, any other friend or any support that you applied for in the asylum accommodation?
Only just the accommodation, just other residents in there. I don't have any friends or relatives there in this country.
And how about your bleeding? Is it okay now? And any pain in the tummy or down below?
No, doctor. No, I'm okay.
Any swelling in the legs?
No.
Okay. And Laura, have you started breastfeeding your baby?
Yes, I'm trying to breastfeed. Yeah.
Okay. If you find any difficulty, then I will put you in contact with the breastfeed nurse as well, so that it will be easier for you, and you will learn a lot at how to breastfeed your baby. Okay, Laura? And Laura, do you feel any? I understand that you are not able to sleep because you are quite worried about your baby. Any feeling like you are fearful, or you are feeling that life is not worth living? Any mood swings you feel right now?
Yeah, I mean, because of this, what all happened, and then I'm alone here, and I've not been able to sleep as well. So, yes, I'm feeling really low at the moment. I'm feeling like it's not really worth living. Yeah.
And how about your eating and drinking? Have you started taking your diet normally?
Yes, I'm trying to. I have taken some drink, but I'm not able to eat anything. I don't feel like eating.
Okay, Laura. And what about your waterworks and bowel movements?
I haven't opened the bowels yet, but I have passed urine. Yes, thank you.
So Laura, Okay. Thank you very much for sharing this information, Laura. Laura, as you told that you're feeling low, I understand that it may be due to the reason that your baby was admitted in the special care unit, and you are alone here, I understand. So I can arrange a counselor for you. This experience might be difficult for you because you're alone here. So if I arrange an appointment with a counselor, it will be, you may feel better talking to the counselor. Okay. How do you feel about it? Okay. And sometimes what happens is that due to hormonal changes immediately after the delivery, it is quite common that the different females, they behave differently in this period. Sometimes there may be some mood changes, and you may feel that life is not worth living. All right. So, Laura, we need to be very careful regarding this because sometimes these symptoms, they can get worsen, and in that case, you need a proper monitoring. Okay.
Okay.
Okay. Do you have any previous history of feeling like this?
No, doctor.
Mm-hmm. So I will immediately I will arranging a special nurse and a doctor who are trained to deal in this situation. And as I understand that your baby is going to be discharged today. So anytime if you feel that I'll make you in contact with the special nurse. So you'll be in contact with her anytime if you feel that there is some aggressiveness or severe mood changes. Then you'll be immediately shifted to the hospital. All right.
Okay.
Okay. And I understand that I will talk to your asylum accommodation as well. They can arrange some support for you because so that you can take care of your baby well. And let me tell you that we have a very good center that we call as Mother Baby Unit, in which you can be there along with your baby. And it is a very good advantage of having this baby mother unit because you will be under continuous monitoring by our staff nurses. And anytime if they feel if you feel need of any support, then they will be around to give you support. How do you feel about it?
I would like to go home, doctor, with my baby. I think I will be better off.
Because because you will be under good monitoring by our trained staff, and they will help you breastfeeding your baby and looking after your baby as well. All right. Any other concern you want to share today?
No, that's all really. I would like to, take baby home.
We talked about the sleeping pills, Laura. So, because you said it, generally, I think that when I will shift you to baby mother unit, you might feel quite good in that case. But still, if you have the sleeping problem or anything like that, because at that place, there will be a lot of support to look after your baby. So, if still you have some problem regarding sleep, then I will refer you to a psychiatrist, and they will write down some medicines for you.
Why is psychiatrist need to write down, doctor? Why can't you write on me a tablet? Sleeping pill.
Yes, because sometimes you may need to, the doctor may need to assess you more. That if there's any other things, sometimes because they are the experts that deal with these pills. But I will keep you under observation. If you feel that you're not able to sleep even in the mother baby unit, then we'll definitely start these medications. Okay.
Yeah, I really need this pill, doctor.
All right.
To help me sleep because I'm feeling very anxious.
Okay. All right. So I'll write it down. All right.
Okay, thank you. Okay, I will stop you here now because the time is over.
Yeah.
No, it's fine, Faiza. Your way of talking is very good, very nice. Obviously, just a bit of more organization in the answer to improve your time management.
Okay, ma'am.
Right. So a couple of things first. Regarding writing the sleeping pill, there's no problem. There's no problem at all to write on a sleeping pill for this woman, right? You don't need to have any psychiatric assessment done before we can give her a pill. You don't need to really, or any interactions or anything. There are some medication which is not, they're not dependent or something. So it's not uncommon basically when the women have any really that type of stress to give them, or sometimes even after the surgeries in gynae as well, to give them sleeping pill for a night or the second night. So it's absolutely okay. So
Excuse me, ma'am.
Zopiclone, yeah.
Yeah, ma'am, but this patient is already saying that she feels that life is not worth living and she's quite
Yeah.
depressed. So don't we need psychiatric assessment for
Yeah,
this patient?
so yeah, you need to do that, but you haven't arranged that. Yeah. So a psychiatric assessment has nothing to do with the pill.
All
So
right.
do that's a separate thing, okay? But I'm coming to that one in a minute, because I think you did miss the red flag symptoms here when she said it's not worth living. If you say it's not worth living, we need to ask red flag symptoms like suicidal thoughts and these thoughts of harm to the baby. So when she says, well, yeah, I'm feeling it's not worth living, then the next question should come and say, okay, so, in that case, do you get any thoughts like, trying to end your life or take your life? And if she says yes, then you even need to ask about that. So what type of thoughts or ideas you're having in your mind? How will you take your life? Okay, this is important. And then also to ask about and how you feel towards baby. Did you feel affectionate and loving towards your baby? Are you feeling kind of tired, irritated, and fed up of the baby? Okay, so these must be asked. She appeared quite depressed, isn't she, from the tone, from her style, and she's saying I'm quite low in mood. Okay, so that needs to be assessed. Baby mother unit, you decided, she says I would like to go home. You're not actually addressing her that thing when she says I would rather like to go home. And the baby is getting discharged today, then you need to basically correlate with that by saying, yes, we are going to make your discharge plan. Yes, you may be well enough and fine, and the baby, you will may be able to go home with your baby, maybe by tomorrow or so. But it is very important that we call our specialist doctors who deal with these mood changes. We call them perinatal mental health team to come down, speak to you, and assess to see how much able you are to cope with all this stress you're going through, because pregnancy itself is a condition. When you have the delivery, because of the hormonal changes, that can also contribute towards the low mood and even depression. And then at the top, you're already feeling anxious because of your baby. That may actually lead you to get like serious mood changes, and that can make you really start feeling ill to the level where you may not be able to look after yourself and to your baby. So it's very important that I contact them to come down and do that assessment, and then we make the discharge plan. Sometimes then, under circumstances like yours and the feelings you're having, we decide either to keep you on the ward a bit more longer, to observe more closely how you are coping with your stress. And if you have any concerns, we then have a unit called baby mother unit. So we may decide actually to shift you there for a few, days or even weeks. And then obviously just check with her to say how you feel about this. And then you can explain the baby mother unit if she asks, or even she says, no, I want to go home and blah, blah, then you can say, it won't be safe to go home like this. So the baby mother unit is the environment that is very much like home environment. You will have your own room where you can keep your baby with you as well. There will be a lot of support available. There will be the nurses around. There, the baby can be looked after. And then, according to your mood changes, you can be starting an appropriate treatment and on the counseling or any other measures you need to support you. Okay. It's important that we do not make any immediate decision that you should go home. Then we need to ask her about, so you did establish about the sport of the partner, and she said, I don't have anybody at home in there as well. So this woman basically, now, number one, she's at high risk of postnatal depression. Then she doesn't have any family support around. She's living in a shared accommodation. So we need to involve social services, and we need to arrange support worker for this lady. So I will say to her, now I can see you've been living over there, and you said you don't have any family members and family around to support you. So it can be quite difficult for you to, you know, deal with this and cope with this whole situation. So what I'm going to do, if you feel it is okay, I can contact the social services and try to arrange a support worker for you, who can visit you at home when you will be discharged and help you to, you know, deal with your day-to-day matters. She can also then try to arrange your accommodation on priority basis. Yeah, because that's another thing we need to sort out for this woman. And then, yeah, so then arrange counseling as well for this. Right, so coming back to the model typical, I just go through as a summary. At some stage you said, when she said, I'm guilty, it's because of me. You said, nobody is going to blame you. We're not worried about other bodies, anybody else who is going to blame or not, right? This is not the answer. It's not that she's worried about somebody else will blame you. She's worried, she herself feels she hasn't done what she should have done. So to address that answer that you need to say, well, I will say, Laura, don't worry about this. There is nothing which you haven't done, or there's nothing different you could do to prevent it from happening. So we're not going to say to her, it was your first experience and pushing can be difficult, because it only says instrumental delivery. We don't know why that instrumental delivery was done. And even if it was only maternal exhaustion, if we say, yes, it can be, she's further going to feel and strengthen her feeling that it was her. She could have pushed a bit more harder. No, just simply say, you know, sometimes it just is the situation, you know, the baby's head is high, or the baby is not coming down with the contractions, and we can only wait up to certain time, you know, and then we need to give some assistance. So I will say, don't worry, and the baby has recovered nicely. And that these type of problems usually are temporary. Try to reassure as well. Yeah, she's repeatedly saying, is that going to be? However, you can keep an eye on the baby at any stage. If you feel the baby is not, you know, feeding well, or there's any difficulty, then please let us know immediately, and the baby will be examined. However, most of the time it's just a temporary immediate thing, and the babies don't have any problems afterwards. So reassure her that as well. Okay. Yeah, so typical then template, follow that template first by asking, okay, so I have, you know, I've seen to you and I can see you have instrumental delivery and the baby has some difficulty, but the baby is doing fine and baby is with you now. Then you can ask, you know, how, so establish our immediate well-being first, which you did. So ask about, has she eaten, drink anything? Has she been able to sleep? Has she passed urine, opened the bowels? Is there any pain anywhere? And then baby as well, has she been able to establish the baby feeding? Is she breastfeeding? Or what's going on? Is the baby feeding okay? You know, are there any concerns? Because this baby was sick before, so we need to also make sure and check that the baby is okay. So you need to ask, is baby feeding well? And this baby okay? And then you need to further, we have discussed that all. Then you further need to go into my say. So tell me exactly what is making you so anxious and worried about things. And then just go ahead with that assessment as we discussed. It's important to say discharge plan. We will, so I'm going to discuss with those colleagues. They will come down and discuss with the consultant as well. So then according to the assessment, we will make your discharge plan when you should be discharged. Okay. Okay. Any quick question before we go to the next one?
Dr. Safia, she asked about the name of the pill. She told me, what will you write for me?
For the sleeping pill.
Yes, Dr. Safia.
Okay, so then you need to say that I will check. Are you taking any of the medication? Are you aware of any allergies to any medicine? And then you will say, I will write you, you know, the one pill for tonight to help you to sleep, and then we will further assess your needs. And once those specialist doctors are here, they will assess you as well. So the tablet I'm going to write down is called Zopiclone. Okay, that's called Zopiclone. This is a group of medicines which are, they don't lead to the dependency. So they can be given.
Sorry, again the name spelling again, Dr. Safia, please.
I write down in the group. That's called zopiclone.
Okay.
Zopilamide. Zopiclone is commonly the name used. I just text in that group as well. Okay. Right. So yeah, I have posted on the common group. Sleeping pill name is Zopiclone. So next one, Sundas, is your turn now. So we need to write at the same time of consultation. Yes, you can prescribe one pill straight away. We know she's saying I haven't been able to sleep. So she might be feeling that low because she was so anxious that she was not able to sleep. So, once we make actually her to take a good sleep, she may be fine actually and start recovering from those signs and symptoms. And then we may not need to keep her. But obviously, you still need to call your mental health team to come down and do the assessment. And for the time being, we're just going to go. It would be a good idea to stay here, for some more time, at least for 24 hours, so that we can assess and see what should be the good discharge plan for you. Okay, so Dr. Sundas asked, ma'am, my baby is still very irritable. Can't do now, sorry. Oh, sorry, sorry, Sundas. I thought you were asking about the patient when I said ask about how the baby is. And I thought you were saying if the patient says the baby is irritable, what to do. Sorry, no, it's Sundas baby is a bit upset, so Sundas can't do this scenario. Okay, anybody else? Mehreen, are you there?
Hello, ma'am.
Yeah.
When are we going to tell about that CBT talkative therapy? Here there is no need, ma'am.
Okay, so at this stage, because we don't know what she needs. So when you say counseling, so counseling is, this is a part of CBT. So at this stage, this is what we need to do. But if somebody has been diagnosed already, so, then you can say, there are like, are you receiving this? And if not, I'm going to name this for you. It's called cognitive behavioral therapy. In simple words, it's also called talking therapy. So, but for this women, basically, you need to talk about the counseling at this stage and the assessment for the mental health by those specialist doctors to come down.
Ma'am, for suppose in structured discussion, if they ask your unit does not contain mother baby unit, what will you do then? What we have to answer?
Okay. Right. So the first is almost all the hospitals do have a baby mother unit. And if they don't have on the site, there will be regional baby mothers unit. So it's not like something that the patient needs baby mother unit and there is no place to keep them. This patient certainly is not going home if she needs baby mother unit. So you do have baby mother unit with every hospital. If not, then there are, the regional centers, baby mother units. So they will be sent over there. They will be kept over there. Okay.
Okay, ma'am.
Any other question? Is Dr. Mehreen with us to do the next scenario? I think Mehreen is not with us today. Okay, so Sundar says she did have that scenario in the exam, and patient didn't say when she asked, she didn't have any suicidal thoughts and no red flag signs. So still mother baby unit, I have to say. Right, so although she doesn't have at the moment, but still we need to, yeah, she appears low in mood. So we still need to monitor her for at least, we say we'd like to keep you overnight. So give her that sleeping pill to help her to sleep nicely. And then say, so you're feeling a bit low and anxious at the moment, maybe because you are worried about the baby and you are unable to sleep. So instead of rushing to go to home immediately, it will be better we keep you overnight, give you the sleeping pill, help you to take a good sleep, and then tomorrow assess you again and see how you're dealing with that. And then it's fine. If she's not obviously she's okay and she's not having any suicidal thoughts and low mood, and she feels them by saying, you know, I'm fine, I will be okay to deal with that, then yes, we will discharge her. Okay. So in fact, she was very quiet, not responding much, and just looking down. That then simply means that she is depressed. Okay. So although she's not gone to that extreme where she can start having suicidal thoughts, but these are the clues, these are the signs. If she's not making eye contact, she's looking down, she's kind of withdrawn, then obviously this woman needs to stay in, and then we will go along to talk about that. I'm going to discuss with those doctors as well to come down and speak to you and assess your needs, and then then you will say we may need to, you know, we may, you know, offer you to stay on our baby mother's unit for some more long time, because sometimes, you know, the symptoms of feeling low, they can very rapidly progress to very severe depression, which can, you know, put your risk and your baby at the risk as well, because, you know, sometimes it can put you to have the suicidal thoughts or thoughts of harm to yourself and to the baby. Okay. Right, okay. Is there anybody left here from Saturday or Sunday group who are attending today, but they have not done the scenario yet? No, there isn't anybody. I think I have no response. Okay, let me just pick up anybody now then. Gulfisher? Hello, Gulfisher, are you there? No. Mala, would you like to do the next one? Because you couldn't do your turn, the cardiac arrest one.
Yes, okay.
Okay, Mala, this last one is for you now then. Okay, this is for you then.
Hello.
Okay, yes, this is your first 2 minutes.
Hello.
Hello, doctor.
Yeah, I am Dr. Mala Ramesh. How I can address, can I confirm your name and age?
Yes, my name is Dawn Wood, and I'm 31 years old.
Yes. How would you like me to call you?
You can call me Dawn.
Yes, Dawn. Dawn, as I can see, this is your postnatal checkup after 6 weeks of your delivery. Am I correct?
Yes, doctor. I had, I delivered 6 weeks ago, and I had forceps delivery, and there was a tear down below, which I was told has extended up to my back passage, and it has healed, but I'm having a lot of problems with that. I'm not able to have a control on my stools. I'm leaking all the time, and I have to use incontinence pad, all the time, and it's so embarrassing, obviously, and I feel like I'm having the bad smell all the time, and it's really, making things harder and difficult for me, and I'm really worried that will I have to live with this now? It's just that's it.
Yes, Dawn. I can take it. It's a difficult situation for you, and it's really affecting your life, and you are feeling not well because of these complications. But Dawn, as it can happen in some cases, and, so we will see about you for this for your concerns. Are you feeling this in no control on the faces all the time? Or sometimes you feel okay, you can control it.
No, I don't have the control.
Uh,
It's just
uh,
leaking all the time.
Okay. And are you underwent for some physiotherapy, Dawn? Are you under some physiotherapy for this?
Yes, I have seen physiotherapy, and they have told me some exercises which I'm doing, but
Yeah.
it's not helping much. Yeah.
Yes, might be takes little bit time because the until the muscles can take time to control. So it's good to continue this physiotherapy, and we will arrange for you some ultrasound as well to see how is the healing and how is the defect is that. And in most of the cases, the woman will recover well. I will suggest you to continue with this physiotherapy, and we will arrange for you ultrasound, and we will book an appointment for you after after a few months. Then we will again see how is your control, and if after that is this problem is still remain, then we will consult with our consultant and back passage colorectal surgeon, and then we will discuss your case multidisciplinary team, which then we will see what they will do about that. How it sounds for you?
Okay. So, will this be actually, correctable?
Pardon?
Will this be, corrected that at some stage, or I just
Yeah.
have to live with it?
No, Don. It is correctable. It's not lifelong. If it heals spontaneously and you regain the control, it's good. If it's not, then might be you have to undergo after some investigation. If the specialist team will feel okay, you need another surgery, then you can go, and it has quite a high success rate of recovery, that you can regain your control over this and this stool, passing the stool.
Okay. So is this going to now affect my next pregnancy and my delivery as well?
Then that will depend upon at that time how is your recovery. If you are if you gain your control and there is nothing, no problem, you are back, means control on the stool, then means you can deliver normally. Then the discuss again, the option will be given to you. Okay, what you would like to go, whether if you want to go deliver normally, this option will be open if you have no symptom. And if there is some defect is still there, then it will be better for you to go for cesarean section. So at that time, and depend upon the what is your next pregnancy will be. Means if there is another indication to do cesarean section, then you have to go for the cesarean section. But if you recovered well only for this reason, then we will not advise you. But again, your wishes will be respected. What you would like to do. And one thing, Dawn, I want to say, okay, if you are feeling difficulty because of this problem, you are not feeling well or depressed, then if you want, I can arrange for you one counselor if you want.
Yeah, I think that will be helpful because it's really affecting my relationship as well at the moment.
Yes, Dana, I can understand if that. Then even with your partner, if you want to do counseling, then we will arrange for you as well. Don't worry about that. But most of the women will recover, but then we will see after few months how is your recovery. If you recovered well, it's good. If not, then we will discuss your case in group of specialists. How it sounds for you?
Yeah, that sounds okay to me. Yeah, you know.
And do you have good support at home?
Yeah, I mean, my partner is supportive, but obviously, because of this all, he's getting a bit fed up and irritated as well. Because obviously, because of this, we're not able to resume of sexual activity and stuff as well. So,
Yes,
yeah, this is difficult. Yeah.
Yes, Don. If he wants also counseling, then we will can arrange for both of you one counselor, and then you can discuss and might be to help both of you to cope this system.
Yeah. Okay.
And do you have done anything else like pain in lower tummy or any unusual discharge apart from fecal passage? You have some other issues related?
No, I don't have any pain, and yeah, obviously I can't tell you anything about the discharge because obviously my, ventilator is stained all the time almost. Yeah.
And are you something else you want to ask? If you have some other concerns apart that this?
No, well, that's all obviously, I'm really worried whether it will be, healed properly and how long it will take really.
I can understand on its difficult situation, but some women recover very fast, but some might be takes little bit time, and some might be need another surgery. So we will see how you will recover. So, and that, are you feeding your baby?
Yes, I'm bottle feeding because I wasn't feeling quite comfortable to breastfeed him because there's all, going on.
Yeah. Yeah, we'll encourage you to continue breastfeeding for it's good for you and your baby. And we will see this method. Don't worry about that. Continue your physiotherapy, and after 1 month we will see again how is your recovery. And I am
Okay.
giving you some information, written information. You can read about that. And
Okay, doctor.
anything else, Don?
No, that's all I think. So when will you see me again then? I mean,
After 1 month.
okay. All right. Thank you, doctor. Okay, your
Thank
time is over as well now.
Yes.
Yeah, that's fine. You did reassure her, talk about what can improve and all that stuff. Just do a little bit more better organization. So this is a postnatal check, and then she has some complications. So the template, keep in mind. So first you need to, do the routine postnatal check as well. So the routine postnatal check, one is okay, she's having problem in leaking, but you need to establish, whether her periods are back, what contraception she's using, who is her bonding with the baby, is she feeling, stressed or low in mood to exclude any postnatal depression, what sports she has, is baby doing okay, has she started any contraception, has she resumed her sexual activity, and then because she had this significant problem, we need to ask how is that affecting overall her mental health, and also her relationship with the partner as well. Yeah, because if she hasn't been because of this able to, it must be very stressful for both of them. Then you need to go into a bit more detail about asking, okay, so you did take some history about your pregnancy, otherwise fine. So you had that. So you first ask, how was the, because what we need to establish here now is it just is taking time for the strength of the tissue and the tone to come back, or if there are any problems with the repair actually, because yes, it is supposed to be done by the trained personnel, but still there could be some defect in the repair, or there might have been some infection afterwards which might have led towards the improper healing. So then coming particularly to this tier 1, you need to ask, okay, so when you had that tier done, did you take your antibiotics okay? Were there any problems? Did you develop any infection during that time? Then you need to ask about the laxatives. Maybe she's still continuing to take those laxatives. So then you need to ask, okay, so you were given some laxatives. Have you stopped taking them? Because sometimes it can be as simple, they're still taking those laxatives, and that's why they are, leaking. So you need to ask that one as well. Then you need to say, the first thing you need to obviously counsel her to say, I can see it is very difficult and stressful situation, having this incontinence. Obviously that can affect your, feel to make you low in mood and stressed as well. So how you are coping? And how is that affecting your sexual relationship? Have you been able to resume sexual activity? No, your partner, how that partner is coping? I feel it will be quite beneficial if I arrange your appointment to see one of our counselors as well, to help you to cope with this issue in a better way. How you feel about it? Yeah, ask her. Then you establish, and by how that other things are going on, then you can say, so I hope you would have been made an appointment to see the physiotherapy as well. Are you doing those, those perineal exercises? Then to help her to understand what could happen, you can just quickly make a picture to say, so yes, as you have been told, that here actually was extended up to your back passage. So what happens routinely, the back passage is actually kept tightly closed with the help of a band-like tissue, a rubber band-like tissue. We call it as anal sphincter. So this tear means actually, that a tear was actually extended and it has actually broken that band-like structure. And as a result, the lower part of the bowels is not actually, as tight closed should be. And as a result, you are continuously leakage. Now, we do know when these tears happen, they're repaired by the properly skilled and trained clinicians, and it can take time for this tissue to completely heal and to regain its tone and strength back to be able to, keep the end of the bowel completely closed. So there can be reasons. To help it to improve then, it's very important that you continue with your physio exercises which have been told to you to improve the strength and the tone of those muscles and also the tone of the sphincter. Okay. I can also recommend you to use some, some oils, or, some, and do some massage in that area of the perineal muscle. That will also improve the circulation and help to regain their strength more quickly and improve the healing. And then you will say, so that is something you need to do on a long-term basis. Then reassure her by saying that it's not unusual with this type of tear that the women can have symptoms even up to 1 year. But then most of them, more than 80%, will completely have the good control. It will have healed properly after the end of the 1 year. However, I would examine you as well after this consultation to see is it only just a matter of or there has been actually, there may be some defect in the repair that it hasn't healed properly. So then I will discuss if I have any suspicion regarding that, then I will discuss with my consultant as well. And then we may consider to arrange your appointment to see one of our colorectal surgeons just to reassess that. And then if they felt they may arrange a scan of that area to measure the tone of your sphincter. Okay. And then according to those results, if they found that there might have been some defect in the repair, then they may decide actually to do another repair. Right. However, I will be able to inform you about that after discussion with my consultant and after examining you down there, if that is required or not. I will also arrange your appointment to see our incontinence nurse who can help you actually to deal with your incontinence in a better way while we are waiting for your healing to complete and for your tissues to regain the tone back. Then she said, okay, so is that going to be, am I going to heal completely or not? Reassure her by saying more than 80% women will heal completely. The tissue will be able to regain all that strength, tone, and the however, a small number of women may continue to have this problem. And if it did so, then you will be seen by those colorectal surgeons as well. And then, they will do all those tests as I've described earlier on to see if there is any need actually to repeat the repair or what else needs to be done. So when she asks about the effect in the future pregnancy and stuff, then you say if your symptoms are completely resolved and your tone is completely controlled is back by the end of first 1 year, then you should be able to have a vaginal birth next time without any increased risk of recurrence of such tear. However, if there has been any weakness in the strength of the muscle by the end of 1 year as well, then there will be slight increase of actually getting similar type of tear again if you choose to have vaginal birth next time. However, it will be too soon to decide how your labor should be managed next time. We will have a discussion at the end of 1 year as well. So it will be a good idea to keep a good gap in your pregnancy to give sufficient time for your tissues to heal properly. So I will discuss with you in detail about starting on some safe and long-term contraception method, unless she has started obviously already to do that. Okay. So then, and if you remain symptomatic, then we can offer you and discuss you to consider cesarean birth as well. However, we will do the detailed discussion at that point of time. Then obviously, yes, offer her, you have offered the counseling already, offer her again some written information about this. And then reassure her as well by saying that I will discuss, this all with the consultant and let her know if there is a need to refer to these specialist colorectal surgeons at this stage, bubble, surgeons, or we can continue with this the exercises and this monitoring. I will arrange your other appointment in 3 months' time to discuss and also to assess and see how your symptoms are improving. Okay.
Oh, okay, Dr. Satya. I have one I want to know when like this type of scenario, any scenario will come, we have just to refresh the initially care. I can see, okay, this is your post-birth 6 weeks follow-up and you had 4th degree perineal tear, like that. I have to say either I have to let the
Right. So that depends on the role player. Sometime when you have done, you have asked them, and if you can ask like, okay, so sometimes you can start by saying, I can see you are here, for your 6 weeks check. Then she may start herself by saying, yes, I'm here for this, and this is what happened, and this is what I'm having. Then it's fine. But if she just say and she's sitting quiet, then obviously you can then start the conversation by yourself. But most of the time, basically, the role players will initiate the conversation and give you those details themselves to save your time so that you don't end up of asking those questions again.
Okay, and Dr. Safia, like as you said, means as a role player, you said, I didn't start a sexual activity, and you said after the delivery, the recovery was means no complications. So then again, I have to say, did you took antibiotic like this, and did you start a I have that queries, whether if suppose.
So basically, you were supposed to ask these questions to me in the beginning when I say immediate well-being.
Okay, that time I have to say.
Because you didn't ask me, so I added up that information. And that happens most of the time. The role players do that. They will volunteer that information to you. And as I said, like sometime, even in the beginning, when you say, okay, what happened? If she herself give that information to you, then you don't need to repeat those questions.
Yeah,
But
if suppose, actually I have to ask, but if suppose patient initially role player give this, then we have no need to ask again.
Yeah, so the purpose is that you need to have this information before you actually can assess what's going on. So it's fine if the role player give itself, then it's fine. If not, then you need to ask these questions. But the question regarding laxatives you need to ask, because that obviously is something she may not mention anyway, even if she's taking, or she might have stopped taking. So you need to ask that particularly. Have you stopped taking those laxatives? Are you still taking them? Okay. Okay. So that's all for today.
Ma'am, for any postnatal, ma'am.
Yeah.
For any postnatal case like this, if you want to tell about contraception, who will tell, ma'am? Nurses or GP or myself? I have to tell the contraceptive choices in single line.
So there won't be any specific scenario like that is a postnatal patient that you just have to discuss the contraception. If it is a scenario like that is the postnatal patient, and the main purpose of the scenario is to discuss contraception, then obviously you will be discussing the contraception. Then there's a contraception station, contraception after birth. So then you will obviously take the history, exclude, and see whatever, and then you will discuss. But in a routine case like this, when there actually is other ongoing problem, and the contraception you are just addressing as a part of the postnatal check, if she hasn't started any contraceptive method, then you need to say, I will discuss with you and start you on some long-term contraceptive method as well at the end of this consultation. Then it's you will do that. But if she's not there for any reason, then routinely this contraception will be discussed by the midwives, and they will be advised to go and attend the sexual health services.
Dr. Safi, I have one more question. As this role player said, I didn't started sexual activity. So even though I have to say we will start contraceptive.
Yeah, because we are hoping her symptoms will get better, and and she should resume her sexual activity. So you still need to start her on the contraception. Okay. Right then, so that's all for today. So tomorrow we will do new scenarios for the remaining people who haven't practiced from Saturday and Sunday group today, and then I will be sending the both recordings to you all.
Thank you, doctor. So sweet of you.
Can we get Friday recording, ma'am?
Sorry, get what? Yes, you will get
Friday
Saturday recording.
Friday clinical governance.
Yes, you all will get the Friday recording as well. Yes, because that was the whole group. So yeah. Goodbye now.
Thank you, Dr. Thank you, Dr. Safi.
You're welcome.